Hi guys, so I'm gonna get started. Um, oh, sorry, I didn't have it pulled up. Okay. Okay. There we go. All right. I hope that's the right date. I don't even know what day it is anymore. All right, but hello. Hope you guys are enjoying your very, very long block. Let me leave this open. Okay. All right, so I was asked to do some MSK, and MSK, it is important on this exam. It does come up. There are questions on it. Of course, the bulk of this exam is going to be neuro, but what I definitely like, this will come up. This is the most high yield topic, regardless. Like you'll have to study this every time you have to study MSK, brachial plexus. So we're gonna do like a basic intro to brachial plexus, and then like the associated pathologies with like injuring one of the nerves that's located within this plexus of nerves. All right. So, kind of, again, like I kind of said, objectives. I'm going to do phys and I'm going to do some path, but path can be asked because remember, I always say path can always get asked first year if it's in the context of phys. And a lot of the times with brachial plexus, it's mostly path, quote unquote, in terms of like if you get a lesion of this nerve, what action, like what muscle action does the patient lose? So, that's kind of what I mean by path. It's not really like cancers and stuff, but and then I did it a little differently this time. I did questions throughout. I did link at the end, like a really good source for doing questions. I actually recommend it to all my second years that are studying for Comlex, like all the second years that I tutor. I tell them to redo these questions on the website. So I have it linked for you. So I have that linked at the end. Um, I didn't actually formally have questions on the PowerPoint. I figured you guys can just go to the website and just like toggle through the questions. You can kind of go at your own pace. But that's at the end. Okay. So, and then quick note before beginning. MSK, again, huge on Comlex. STEP, not so much. I mean, they do ask MSK on STEP, but it was like night and day, honestly. They ask so much MSK on Comlex. So it's good to start it as early as possible. And like I said, brachial plexus is one of those things that you are guaranteed to get at least a few questions on. So you might as well know it, right? A lot of the second years that I tutor for boards, a lot of them have taken boards this week and last week, and they're confirming, like, yeah, there was tons of MSK, and it's this kind of MSK. It's like MSK Phys. So it's not really like the MSK path that's on in Pathoma. There's a chapter in Pathoma, which you'll be doing second year. Um, there's a whole chapter on it. Um, that does come up, sure, but it's by far like the brachial plexus pathologies, lumbosacral plexus, your sits muscles, so like the muscles that work your shoulders, myotomes, like lumbar disc deviations, things like that. Like that's what comes up so frequently. And the best resource I found, so brachial plexus, it is a little bit of memorization just until you start to get the hang of it, and then you'll start being like, oh yeah, like I know this now. But there's this guy, his name's Intervention. He's more of like a preparing for boards kind of guy. He's incredible. He really works, like walks you through how to answer questions that will come up on boards. That's what I think is so great about Divine Intervention. But one of the things that he does is he basically explains the brachial plexus like how I would do it if I had a lot of time. Like I would go from like this is why the things are called, like this is why they're named the way that they're named. And he goes into it. They're really, really good. So I highly recommend listening to these podcasts for this year, at least these two episodes. He breaks it up into two parts. Fantastic. Very, very good. Um, and then before kind of we jump in like with what I have for you guys today. And again, I didn't go into as much detail as I think you do need for boards. Like, and I'll show you kind of like when you see the plexus, like some people are like, oh, like, should I memorize drawing it out? 100% sure. Like, you should memorize for at least this year doing that. But for boards, they'll ask you about like the random little branches. And I'm not really focusing on that. We're doing basic brachial plexus. Like, it's still going to be a lot of information, but you're going to build on it, if that makes sense. Okay, so you will need to know this stuff eventually, but again, this is a tons of stuff is going to be on this exam. This is a massive block, so I didn't want to like overwhelm everyone. All right, so basically, before we get started, there's like some orientation stuff to get used to when it comes to like, you know, all these muscles that we're going to be talking about. But the hand, especially, I think is confusing. So I wanted to give it its own slide before we dove in. So hand orientation is always described when the hands are in a standing anatomical position. So this is your anatomical position, standing. So if you ever forget, you're ever confused, just imagine standing, palms facing forward. So your palms are facing forward. So see how the pinky is closest to the trunk of the body. This is medial. And then see how the thumb is furthest from the body. That's lateral. And I know you're going to be like, that's obvious, but it gets a little confusing when it talks about certain nerves, because certain nerves innervate. There's like 4 different nerves that innervate the hand. On like some only innervate the palm side, some innervate the dorsal side, and it gets very confusing. So you just have to remember like standing straight up like this. Oh my gosh, which way do I go? This way. So standing straight up, thumb is going to be always out, pinky's going to be always closest to the trunk, okay? And that's on both sides. So if you're ever confused, and we're going to talk about some hand stuff at the end, because I think that's one of the hardest with the brachial plexus, just remember standing anatomical position. Another thing too is they'll talk about numbers, like the ulnar nerve innervates numbers 1 through like 3.5 or whatever. The median nerve 1 through 3.5. The first digit is going to be the pinky, and then the thumb is going to be the 5th digit. Okay, so it goes from 1, 2, 3, 4, 5. Sometimes they'll say like the lateral fingers, like the first. So that's the only time that it's a little different. Like if it'll say like, oh, the lateral 3 fingers, because the lateral 3 fingers is going to be these guys out here. So like 1, 2, 3, it'll be something like that. But if they say like the first digit, that's going to be your pinky. Hopefully that makes sense. And then again, lateral, medial, thumb, pinky. And then other terms, proximal is going to be closest to the trunk of the body, as it always is. Distal's furthest away from the trunk of the body. Palmar side is going to be where the palm is. And then dorsum is going to be on the back or the dorsal side. Okay. So the brachial plexus is just a fancy way of saying this is a network of nerves that form from spinal levels C5 to T1. Okay, so like cervical level 5, 6, 7, 8 to T1. All right. Nope. All right. And this is what I was talking about earlier in terms of like, it is good to know these divisions. So we have the roots, is what we just talked about. So we have C5, C6, C7, C8, T1. Imagine the neck is here where this red box is. So imagine this is a neck, and these are going to be those spinal levels coming out from the neck. And remember, they come out on both sides, right? So they're bilateral. For the brachial plexus, there's these, they call them like different things. So then it's going to form into trunks, then divisions, then cords, and then the nerves. And then that's what I'm focusing on today is the terminal nerves. But you'll see there's a lot of other stuff. So there's like the superior, middle, inferior trunks, anterior, posterior, anterior, posterior, anterior, posterior divisions of those trunks. And then the cords, the lateral cord, the medial cord, the posterior cord. Like I said, these are good to know. These are important to know. I do think it is worth your time to draw these out and have these memorized. And you'll see towards the end, I'm going to go into like certain pathology states where it'll talk about like, oh, the inferior trunk is affected in this condition. And if you know where the inferior trunk is, you can kind of figure out what nerves are going to be affected by it. Like you can see it's the median and it's the ulnar, right? So it's good to at least know, but just know that I'm not going into like a lot of detail in terms of like the pathologies that arise from the trunks, the divisions, the cords. And they can ask you questions about like these random nerves, like the long thoracic nerve. This is going to come up, and you can see it's kind of like a combination of many of these nerve roots. So they can ask questions. These nerves are all fair game, 100%. But what I am focusing on in terms of like just not overwhelming everyone is going to be these like the nerves coming off these terminal branches. Okay, so I just wanted to really emphasize that. So these are the 5 terminal branches. We have the musculocutaneous nerve, the axillary nerve, the radial nerve, the median nerve, and the ulnar nerve. Okay, and you can kind of see them here. Here's the musculocutaneous, here's the axillary, here's the radial, the median, and then the ulnar. Okay, and then all these other names are like, all these other random nerves that come off. And I believe like when I was doing this first year, I did memorize all of these, and I think it was worth it to do that because I feel like they can just ask random questions about the brachial plexus. But like I said, the most important ones are going to be these 5 terminal nerves. Okay. All right. And then my last piece of advice before we kind of dive into like each individual nerve is to pay special attention to the nerve relationship with the bones. And what I mean by that is a lot of the times this is what we talked about. So here would be like the roots coming out of the spinal cord, and then they turn into I already forget the names, the trunks, the divisions, the cords, and then the terminal branches. But like you can see here, the axillary, see how the axillary nerve kind of like wraps behind the top part of the humerus? The radial nerve's kind of like here in the middle. This will all come up in terms of like injuries. So if they say you have like a dislocation of your shoulder, so dislocation of the glenohumeral joint, the axillary nerve is right there. So you already know like you're going to see symptoms of having like an axillary nerve lesion, even though it's not really a lesion, it's just we're taking it out because we have a dislocation of this bone and the bone is right next to the nerve. So that's kind of what I mean by that. I bring it up for all of the nerves, so it's nothing you have to do extra, but just pay attention to it in terms of like when they're giving you vignettes. This will come up. Okay. All right. So starting with the musculocutaneous nerve, definitely know the spinal roots. And what I mean by this is, I'll go back again. So the musculocutaneous nerve comes from spinal root C5 to C7. What that means is if you look at where the musculocutaneous nerve is, which is right here, it's going to be, and if you follow it back, it's going to be comprised of roots C5 to C7. So if we draw C5 goes here, goes here, goes here, boom. C6 goes here, goes here. It splits, so it counts. C7, same thing. It comes up here, and then it goes like that. So C5, C6, and C7 all kind of give rise to the musculocutaneous nerve. That's what I mean by like that's the levels of the musculocutaneous nerve, and you should know those for every single terminal branch. All right, so that's that one. Its function. So what are its functions? So each brachial plexus nerve has a motor function as well as a sensory function. And I broke it up into that because that's what they can ask either or both. So in terms of motor functions, so really quickly though, here's the musculocutaneous nerve. So if you see it here it is in yellow. So they kind of like highlighted like, oh yeah, it's a part of the lateral cord. It's good to know. Like I said, it's a little specific. It will come up on boards 100%. But just again, I'm focusing on the branches here, the terminal branches. So it comes from the lateral cord, and eventually I'm going to have the musculocutaneous nerve. And if you notice it, it's right on the front of the bicep muscle. And again, this is going to be standing anatomical position, so the palm's facing forward. So this is right in the front of the arm. And again, like I said, this is really helpful in terms of like vignettes. Like, let's say someone has an injury to the anterior bicep. What nerve do you think is going to, you don't even have to know what this nerve does. You just know it's there. And you're like, it's probably the musculocutaneous nerve that got affected. So that's why it's good to kind of know its relationship of where it is. So here it is right here in the front of the bicep. So its motor functions is to basically do bicep flexion, obviously. So that's flexion at the elbow. And in terms of like flexion, extension, that I feel like should have been its own kind of like topic, like what shoulder flexion, what shoulder abduction, what shoulder extension, like what are all these things? I'm going to bring them up as they come up, but just pay special attention to if it says flexion, I could be talking about shoulder flexion, I could be talking about elbow flexion. So pay attention to that. If I slip up and don't say one, I usually have it on the screen. But in terms of like flexion, I mean elbow flexion. So what the bicep muscle does, it does flexion at the elbow. And remember, flexion is going to be making an angle smaller. So if I'm flexing at the elbow, I'm making the angle at the elbow smaller by flexing it, right? So that's elbow flexion. And it does that with certain muscles. We'll talk about them, but the major functions that it has is elbow flexion. It does forearm supination. So forearm supination is when let's say my hand is prone like this and I supinate like this. So remember, I think we talked about this very briefly maybe, but like I always tell people, think of supination, you're holding soup. So your palms have to be up. So this is supination. And then it does flexion and adduction at the glenohumeral joint. Glenohumeral joint is basically like shoulder flexion, shoulder adduction. And there's other muscles that work the shoulders, those are like your sits muscles. These are just like ancillary things that the musculocutaneous nerve can help with. So it doesn't have to like be solely responsible for all of these things, but it does contribute to at least a few of these things. So we have shoulder flexion and shoulder adduction, which again, you'll cover with the sits muscles. And if you don't know what I'm saying with the sits muscles are four muscles. It's an acronym. It stands for the four muscles that innervate the shoulder, which are different. Some of them are innervated by brachial plexus nerves, but some of them are not. So I didn't include all of them in here. But again, these are the functions of the musculocutaneous nerve because it innervates some of these muscles that are here. So some of the muscles that it innervates, biceps brachii, brachialis, coracobrachialis. So these are like the three muscles that the musculocutaneous nerve does. And if you look up the functions of these muscles, these are the functions that those muscles have. Okay. So that's why if you have a musculocutaneous nerve lesion, these muscles are going to be at least somewhat affected, and you can't do these functions. Sensory wise, if you lesion the musculocutaneous nerve, you're gonna have sensory deficits. So like think pins and needles or numbness. I've seen both in like vignettes. So either sensory deficits such as pins and needles, numbness, tingling, things like that in the anterolateral aspect of the forearm. So we're down in the forearm, so we're past the elbow, and it's going to be anterolateral. So here's where the thumb is. Remember, the thumb is always lateral, so always lateral. So this is just showing like if like your palms are facing forward, or if you flip your hand and the palm is facing in the back. That's why they show two images. It's not like left and right. They're showing like this is palm forward, and then this is the back of the hand, the dorsum of the hand. So you can see that. That's what I'm saying. Sometimes it gets a little confusing when you're looking, because if I were to look at that, I'd be like, oh, standing anatomical position, this is like, the person's like left hand. You know what I mean? And it's not. It's the right hand just facing the opposite direction. So you have to just remember like lateral means thumb side, versus just like looking at an image and being like, that looks medial. This is probably medial. Just find where the thumb is. That's going to be your lateral side. Okay, good. So anterior lateral aspect of the forearm, both on the palmar side as well as the dorsal side. And this is not always the case. That's why they show it on both sides. Some nerves only do like the back of certain body parts. Some nerves only do the front of like the hand, the back of the hand. It varies. So this does both, and it does the anterior lateral aspect of the forearm on both sides, dorsum and I guess like not like palmar, but like the palmar part of the forearm. Okay. Oh my gosh. All right. So then I have videos instead of, oh, I'm glad these are working. All right. So before I go to that, I do have videos because I didn't want to sit here and just try to like act out all these muscle actions. I think it would be a lot more helpful to see it in a video. So I have these videos showing like, what is supination? What is elbow flexion? What is flexion and adduction of the shoulder, basically? And so this video is showing this. So this is forearm flexion. So basically like you're going to the gym, you're doing a bicep curl. That's forearm flexion. This is shoulder flexion. So shoulder flexion is bringing the shoulder up like that. It's weird. It's not really flexion, and then forearm supination. So that's forearm flexion, is supination, what I talked about. So it's over like this, and then you flip it, you supinate it. So you can hold sup now, okay? So those are the three actions that the musculocutaneous nerve does, because it innervates those three muscles, the brachialis, the biceps brachii, and the coracobrachialis, okay? And that's what these muscles do. Like I said, not all of the brachial plexus things are going to like fully innervate the shoulder. The shoulder has its own muscles for that. But as you can see, there was an aspect that does shoulder flexion, which is just bringing like the shoulder joint up like that, which was in the video. Okay. Okay. So here's a question. You guys don't have to answer it now, obviously, but I wanted to give an example of how they might ask a question about, like even for board style, even for your exam. So musculocutaneous nerve function. So a patient suffers iatrogenic musculocutaneous nerve palsy following a shoulder arthroplasty. So they're basically telling you like they lesion the musculocutaneous nerve accidentally. Which of the following movements will be unaffected? So now you have to be like, okay, well, what does the musculocutaneous nerve do? And it does the three things we talked about. It does forearm supination, it does elbow flexion, and it does shoulder flexion. Awesome. Yes. So this is shoulder abduction. Perfect. And then, so I can see them asking questions like this. Sometimes they might not tell you this. Like they'll say like, and we'll talk about like how you would get a lesion of the musculocutaneous nerve. Sometimes they'll throw that in a vignette. Like I think I have it on the next slide. Yeah. So I'll show you on the next slide. So they'll have that on they'll have that in the vignette, or they'll say like, nerve roots C5 to C7 were affected. So like they can ask it a bunch of different ways. Okay. But very good. Shoulder abduction is unaffected. That's not what the musculocutaneous nerve does. This would have been correct if it was shoulder adduction, adduction. So bringing it in towards which I know I didn't really show in the video, but it's more so shoulder flexion, elbow flexion, forearm supination. Okay, and then how do you get this injury? Like this, I know it told you they had a shoulder surgery, but usually is going to be some sort of upper trunk compression. And again, so upper trunk compression, like I have circled here, if I go back to this image, what that means is like superior trunk compression. So if you can envision where the brachial plexus is in the body, so I'm going to scroll forward really quick. So that would be like right here, this would be like the upper trunk. So imagine an injury to like up here that could potentially injure your musculocutaneous nerve because it's these first three roots that make it up. So that can be compressed by compressing this upper trunk, and then that can affect downstream this musculocutaneous nerve. Okay. Other things that can cause it, and this is usually what's going to be in vignettes because they're not going to say patient suffers from an upper trunk compression, but some examples are going to be shoulder dislocation. So like I said, remember the musculocutaneous nerve kind of runs along here, runs right along where the glenohumeral joint is. So if you have a dislocated shoulder and it dislocates in such a way, like it comes kind of out and forward, it can kind of hit the musculocutaneous nerve and like knock it out. So I tried to draw it here in yellow so you can imagine like it can dislocate and hit it. Baseball pitching can do it. I will put a little like be careful with baseball pitching because the classic nerve that gets affected with baseball pitching, it's not even a brachial plexus nerve, the muscle that gets classically affected. When you see like baseball pitcher, it's like one of those things that you're like, oh, it's this muscle. It's the infraspinatus. It's the eye and the sits muscles. So the sits muscles, again, I'm not covering them in this session, but these are the four main muscles that innervate the shoulder. Infraspinatus is the eye in this. That one is like, usually they'll say like, there's someone is a baseball pitcher, and they have now like an injury to one of the muscles, and they'll describe, like, sometimes they do ask about the musculocutaneous nerve, right? Like the infraspinatus is different from what the biceps brachii does, and the coracobrachialis and the brachialis. So you can kind of get around it that way, but just pay attention to that. Don't like immediately when you see baseball pitching be like, oh, it's musculocutaneous, because it could be the infraspinatus. It could be any of the sits muscles, honestly, with a baseball pitcher. So see kind of like what function they're giving you that's defective, or just kind of what the question's asking. And then lastly is the third option anterior bicep? Yes, exactly. So bullet to the anterior, tricep, bicep. Yes, good catch. No, you're good. Good catch. Bullet to the anterior bicep. I feel like this is still technically right. The anterior tricep would probably be the bicep. Technically, it's kind of a weird thing. But yeah, I'm going to change this before I upload it. So bullet to the anterior bicep, like I said earlier, front of the arm, right here, right? As soon as you, boom. And it doesn't have to be a bullet. Like, I think that was just an example that was given, but anything to the front of the bicep muscle, because it runs pretty superficially right along that bicep muscle. Okay, so again, here's the nerve in yellow. If you have like a bullet to the anterior bicep, boom, it can take out that nerve. Okay, and then main symptoms following injury, like I said, always think motor, always think sensory. So motor, as like kind of a summary, you're going to lose forearm supination. You're going to have difficulty flexing elbow. And again, the reason I don't have shoulder stuff in here is because these are not the only muscles that innervate the shoulder. So even if you have a musculocutaneous nerve injury, and like let's say your coracobrachialis isn't functional anymore, you have those sits muscles that can kind of still help with like flexion and adduction of the shoulder. It does do that because of the coracobrachialis, but it's not going to be like a deficit if you lose it, because we have other muscles that do the same thing. Okay, so if you're ever confused why I didn't include it, but I talked about it, that's why. There's usually another muscle that can kind of like take over. And then sensory deficits, like I said, lateral forearm on both sides. So this is the front of the arm, we lose sensation. Back of the arm, we lose sensation. All right? Okay. So next is the axillary nerve. So the axillary nerve is made up of spinal root C5 to C6. If I go back, here's going to be C5, C6. If you trace them, oh my goodness. All right. No. Guys, you know what I mean, but here we go. So C5, we're going to go. It branches posteriorly, and then boom. So here's axillary. Here's C6, same thing. It branches, and then it goes, and then boom. So here's your axillary nerve made up of spinal root C5, C6. Okay. So the functions of it. So its motor functions are going to be abduction of the glenohumeral joint. It basically innervates the deltoid muscle. That's like the main thing that the axillary nerve does, is it innervates the deltoid muscle. Yeah. And the deltoid muscle, it does at abduction of the glenohumeral joint. So basically this function. And I have a video to show you again if you can't really see what I'm doing, but it like abducts out at the glenohumeral joint. So this was flexion at the glenohumeral joint. Now we're doing abduction, so out. Like you're making wings. That's like abducting. It also innervates the teres minor, and the teres minor is really big for external rotation at the glenohumeral joint. Okay, so external rotation. I have a video to show. It's kind of a weird thing. It's kind of like a movement backwards like that, but I'll show you in the video. But that's what the axillary nerve does. It innervates these two muscles, and these are the two functions of those muscles, external rotation and abduction, both at the glenohumeral joint, which is basically the shoulder. Here is the axillary nerve. So again, like I said, like pay attention to how it kind of where it is in terms of bones. This is going to come up for in terms of like the types of injuries that can injure the axillary nerve. It literally wraps behind like the top part of the humerus, and then it wraps around it. So you can imagine any sort of like dislocation can kind of take out the axillary nerve. And then in terms of sensory, this is like usually, like I said, they're going to show you anterior and posterior. That's probably better than palmar and dorsal like I'm talking about, but you know what I mean. So the front and back, it's on both sides, which is good. So it's basically this part over the lateral deltoid. So literally where the deltoid muscle is, you'll lose sensation there, or you'll have pins and needles and tingling on both sides. And they call this the regimental badge area because it's like, you know, like if I don't really know regimental, but in terms of like, you know, if you're playing soccer or something and you see people wearing like the captain bands, that's like, it's like a badge. So they call it like a regimental badge because imagine like someone wearing like something on their arm, that's where it would lay. You lose sensation to everything that it's touching. Just like if you were to wear like a regimental badge of some sort, you'd lose sensation here. So this is where you lose sensation if you have an axillary nerve injury. It's kind of easy to remember because it matches up really nicely with the deltoid. So this is shoulder abduction. So this guy's facing forward, and then it's just abducting out, right? So I'm going to do that again before we do external rotation. So going out, so abduction. So from the front and then over there. And that's mostly your deltoid. This is external rotation. I know it's a weird video. I could not find external rotation like anywhere else, but that's external rotation. Want you guys to see it again. But like I said, it's kind of like, and it's always at the glenohumeral joint. So it's kind of like we're externally rotating back like that. So like I said, this is a baseball player. You can imagine like the axillary nerve can be injured with a baseball play, like a baseball pitcher as well. So it's not just the infraspinatus, not just musculocutaneous, but it does come up more so with those two than others, but fair game for any of them. Okay, and then axillary nerve function. So the illustration below shows a patient with long-standing axillary nerve palsy. Which muscle has atrophied? So they kind of show you this image. And it looks like basically like there's this muscle here that looks nice and firm on the right side, but over here it's super, super, super flat. So they ask like, what nerve is this? And this is going to be the deltoid, if we couldn't get that. I've said that multiple times. Deltoid, very, very associated with the axillary nerve. This is called deltoid flattening. This is like a telltale sign of axillary nerve palsy. So even if you see this is like buzzword for axillary nerve palsy. Yeah, you can really see the difference between the two. And I have another picture to show you, like on the summary slide. It's very obvious that there's a flattened deltoid. I feel like this came up on my exam first year. It literally showed a person and one side was like completely flat and you're like, whoa. And then they asked some sort of question about the axillary nerve. What nerve roots? What is the nerve? What's an action of this nerve? Like what's an action of the muscle that this nerve innervates? Something like that. But as soon as you see this can be like, yeah, this is a axillary nerve palsy. So it's called deltoid flattening. But other things that can kind of cause injury to the axillary nerve, like I said, pay special attention to where it is. It wraps around the top part of the humerus. So obviously, number one, fracture at the surgical neck of the humerus. So the surgical neck is going to be right where basically like right where the axillary nerve is basically. That's the neck of the humerus. If you can imagine like this is the head, this is the neck. So you can see in this X right here, there's a clear fracture right there. And obviously you can't see nerves in x-rays, but again, the axillary nerve wraps like right here. So it can get affected by this injury. And typically the patient type you see this in are elderly people. Like a lot of the times you don't really have fractures at the surgical neck, like all the way up there, but in elderly people, it's a little bit more common. Another thing is if you have an anterior dislocation of the humerus, like I said, it kind of, I think this is a better picture to kind of see it. It wraps around in the back and then it kind of comes forward. So if you have an anterior dislocation of the humerus, so imagine this coming out towards you, like on the screen, you can just like bring the nerve with you and it can just completely damage that nerve. So that's your anterior dislocation of the humerus. This is usually a sports-related injury. So someone's playing football, baseball, soccer, something like that. That's when you would get like that anterior dislocation of the shoulder. Okay. Again, you can't really see it, but if you can imagine, the axillary nerve kind of comes behind and then it wraps in the front. So if it comes out, it's gonna like pull it and it can really injure it. And then here's your summary slide. So here is what a flattened deltoid looks like. So again, super obvious. Like it's very obvious that someone has a flattened deltoid. And the reason I say that is like this could look normal in people, but compare it to the other side. So like look at the other side. If the other side looks a lot bigger, then that's flattened deltoid. It's not just, someone's not just gonna like exercise one of their deltoids and the other ones, no. Like this is what happens in terms of axillary nerve injury. You get like atrophy of the deltoid muscle like super quickly. And then this is another thing to kind of, in terms of like the sits muscles with the shoulder, is a lot of the times they want you to know like the exact degrees of abduction of the shoulder. And the deltoid muscle doesn't do the initial 0 to 15 degrees. That's another muscle. But the deltoid muscle kind of takes over from like 15. I don't think it's just over 15. I think I did this for simplicity. I think it's like 15 to like 100. I forget. But it's like from 15 to something else, the deltoid takes over. And then it's another muscle, and then it's another muscle. So all four of these help with deltoid. I don't know if it's actually all four of these, but a lot of the sits muscles help with shoulder abduction. It's just they have different degrees that they help with. So it's like the supraspinatus is like 0 to 15, deltoid's 15 to 100 or whatever, and then it's another muscle. Okay, so sometimes they'll talk about degrees. Don't ignore it because that's specific in terms of like the muscles themselves take over at different degrees. All right, so the deltoid's like 15. It's in first aid. I think it's like 15 to 100. And then sensory deficits, you're going to lose sensation over the deltoid muscle and lateral arm. It's that regimental badge area. That's like, again, how they kind of reference this. Okay, and I always say loss of sensation, but remember, like I can mean like pins and needles. Like it can be anything where it's like you can tell like something's wrong like with a sensory issue. Like it's pins and needles, numbness, tingling. It's all the same thing. All right. Next is the radial. So we're going to get a little bit more involved now because now we're getting the hand involved. And like I said, the hand is where I think the brachial plexus gets a little bit more complicated personally. And as you can kind of see, we're kind of making our way down, right? So we were in the musculocutaneous. It was very shoulder, the axillary, very shoulder. Like we're kind of up. Now we're going to start making our way down a little bit more. We're going to move down the arm. Radial nerve C5 to T1, which you're like, isn't that just the entire brachial plexus? Yes, and the radial nerve is basically made up of the entire brachial plexus. So here's the radial nerve right here, and you can see if you follow these down, every single branch is basically providing to the radial nerve. And you can kind of follow here. Oh, this one I guess doesn't. Oh wait, no, it does. It has this deviation here up to posterior. Yep. So C5 to T1. I only trip up like this sometimes because sometimes the levels are different depending on source. But if you can follow it with, what I just did right here, then it's likely considered a branch. So the radial nerve is made up of pretty much every single branch in the brachial plexus. So you can imagine like lesioning this is going to be pretty substantial. So C5 to T1. So the radial nerve, there's a lot of branches of it. It's a pretty long nerve. It runs down like the entire arm. Mostly the motor functions of the brachial nerve are coming from the deep branch. So it does both the arm and the forearm. So I kind of broke it up into like, here's the forearm functions over here. Here's the arm function. So I'm going to start with arm because, I'm making my way down. So here's the radial nerve coming down the arm. The first thing it hits is the triceps. So that's the first muscle it's going to innervate. The tricep extends the arm at the elbow. So I can't really do it right now. There you go. There's tricep extension. It's like if you're in the gym, you're doing tricep extensions, you're working your tricep muscle. It's your radial nerve does that. So it's going to extend the arm at the elbow. And then that's the main thing it does in the arm. And then it kind of, you see it branches off into like the deep branch. That opens up into like a lot of these different forearm muscles. And I'm not going to lie, there's a lot of forearm muscles that sure are important to know eventually. But in terms of your exam, this is like the best way I kind of explain it. So Supinator. This is a very, very important one. So I highlighted this. This is a good one to know. What's its function is to supinate the forearm. And I want to point out here, remember the musculocutaneous did have a supination function. So that is also involved in supination. So you're going to have to see in terms of like the vignette, like what other muscle functions are gone. What was the injury? The injury for musculocutaneous nerve palsy is going to be a lot different from a radial nerve palsy. So kind of like so good question. So just for the recording, so both innervate the supinator. The radial nerve innervates the supinator, which its only function, primary only function is supination. That's the only thing this muscle does. The musculocutaneous nerve innervates the biceps muscle, which everyone only thinks the bicep does elbow flexion, myself included. I thought that was like, that's why you go to the gym, right? Elbow flexion. The bicep muscle also can do supination. So it can also do supination. It's like a lot. Yeah, it's weird. So it's like, it's still only innervating the bicep, but the bicep can supinate. And I feel like this comes up every now and then in terms of like, let's just say the vignette said the only injury, like the only thing that, you saw in a patient was loss of supination. You're like, and then it's like, what muscle is that? Or not muscle, well, not what muscle, sorry, like what branch of the brachial plexus is this? Is it the musculocutaneous or is it radial? And I would just say, and this is again my personal opinion because I get this question a lot, I would say the radial nerve would be the culprit there because the supinator, that's all it does, right? Like the supinator muscle, all it does is supinate. The biceps muscle, if you had a biceps injury, you would lose supination, sure, but you would also lose elbow flexion. Like primarily, the biceps does elbow flexion. So if you're only getting loss of supination and elbow flexion is fine, I'd be like, that sounds more radial nerve to me. Does that make sense? I don't know if that's the right way to go about it, but I'm pretty sure that makes more sense because again, the supinator, it's named because it primarily supinates. The biceps does not primarily supinate. It just also does it. It happens to also do it. Okay. So that's kind of like an interesting little thing to keep in mind with the musculocutaneous. Oh yeah. So the deep branch of the radial nerve, another name for it is, so once it goes in, this is where kind of like the brachial plexus stuff gets a little more complicated, but we're not going to get into that level of detail. But here comes the radial nerve it's coming in. This is the deep branch. It's going to like innervate the supinator. And then when it comes out on the other side, it suddenly called the posterior interosseous nerve. Okay. And it's because of the artery that innervates the muscles that are around here. They just named it, but it's the same nerve. So if you see posterior interosseous nerve, it's just the radial nerve just going down the forearm. All right. So that's just another name. So I put here like, oh, it's another name for the radial nerve. And then I also think of, in terms of like memorizing all of the freaking muscles in the forearm, because there's a lot, and I'll bring up the important ones. The radial nerve also does other muscles of the posterior forearm. So just all the other muscles kind of that are located there. And like I said, I'll bring up some important ones, but there's a lot. But the functions of these forearm muscles is to extend the wrist and extend the fingers. And I have videos kind of showing that. But extending the wrist, let's say my wrist is floppy like this. This is wrist extension, okay? So here it's floppy, extension. So it's not like crazy extension. Like this is also extension, but it's just also like just bringing it back up to neutral is wrist extension. And then finger extension is finger extension. So I'm extending my fingers. Yes, exactly. So the question in the chat, it prevents wrist drop, 100%. And we're going to talk about that's a huge sign of radial nerve palsy is wrist drop because you can't extend. So now your wrist just like, you walk around like this. That's called wrist drop. So I have a picture of that to show you. But these are the motor functions. Here are the sensory functions. There's a lot of stuff because again, the nerve is so long, it kind of goes down. And however best can help you remember this is just gonna, however best. So this is the anterior side. So the palm's facing up. This is the posterior side. So remember, this is not like the left arm, the right arm. So like we've been talking about anterior, posterior. So when the palm is facing towards you, you can see it does the lateral aspect of the arm. This looks super similar to the regimental badge area, but that's a little bit higher. That's up here because that's where the deltoid muscle is, right? So we're a little bit further down. So we're at the lateral aspect of the arm. So that's one that's kind of like, yeah, you should remember that. Where it's like in terms of like you might have to like memorize that a little bit because it's just kind of random. But if we flip it over to the back, so the posterior side, that's where you're going to see like it innervates the posterior surface of the arm. That's not as something that you really have to remember, like memorize too much, because the tricep is like right here. So if you know the radial nerve innervates the tricep muscle, boom, it does the posterior surface of the arm. Then as it kind of goes down, and like that's what these little color coding is. These are like the radial nerve as it's sending off its branches. These are the names of these branches, but I really don't think they'll ask that. I've never learned all of these and it's been fine. If there is a branch that I think is important, I'll bring it up. Like the superficial branch, I'll bring it, like for different nerves have like superficial branches. Those will come up in vignettes, so I'll bring it up. But this is like, it's just good to know. Like this is just sensory innervation of the radial nerve. Okay. So this is this. So here's the posterior surface of the arm where the tricep muscle is. Then it does a strip of skin down the middle of the arm, but on the back. So remember, on the back here. So like, I guess like right here. Like, so here's the back of my hand, just like right here. It does like a strip of skin right down the back. Okay. So that's radial nerve. And then the hand. And we're going to go into the hand because the hand, I'm telling you, is where the brachial plexus loses people when it comes to the hand because it's really annoying. But this is one of those things I'm telling you, you can see the radial nerve is only doing the back of the hand. There is no innervation on the front of the hand, which is wild to me. So it's only on the back. It's only on the dorsum of the hand or you're going to get any radial nerve symptoms, okay? So just pay attention to that. And then in terms of this, dorsal surface of the lateral 3.5 digits. So it's telling you the lateral 3.5 digits, that's going to be thumb, and then the ones next to it. So thumb is going to be, because again, lateral, that's always going to be thumb. So thumb, first finger, second finger, and then half of the fourth finger. Okay? So we have 1, 2, 3, and then 3.5 for 4. Okay? So 3.5. And again, it's going to be so it's going to be the finger as well as the associated area on the back of the hand. So it's like the finger parts, but then it's going to extend into the hand as well. All right, and we'll go into the hand a little bit more in terms of like there's certain things to remember with the hand, but this is pretty much if you can remember, like if you can associate the radial nerve with like where the thumb is, it'll help you with in terms of like, okay, then it just remember it does the back of the hand. So it does the back of the hand where the thumb is and like the first three, like the 3.5 digits next to the thumb. Okay. All right. So here's all the things that it does. So here's elbow extension. All right. We're going to go back. So here's elbow extension. That's what your tricep muscle does. So again, extending there. That's wrist extension. So wrist extension. There's your finger extension. All right. So these are the three main things that the radial nerve does. Elbow extension, wrist extension, and then finger extension. And all of these things are like it's on the back, right? So it's like the triceps is on the back. It's doing extension. Wrist, it's doing extension. It's things on the back, fingers, extension. That's how you can kind of remember it does the back of the hand. And it's also like staying close to where the thumb is. So it's going to be like the back of the hand of these fingers over here. All right, so the question here, which of the following muscles would be affected in a transection of the superficial branch of the radial nerve? And I think I highlighted superficial branch, and I'll just kind of go over this one with you guys. But remember that the motor is mostly the deep branch of the radial nerve, so you're going to see motor issues versus the superficial branch would be one of these guys, which is more of you'd see more sensory issues. So I'm just going to give you guys this one. This was a true trick question. This is none of the above because these muscles are all innervated by the motor, like by the deep branch of the radial nerve. So they're all they are radial nerve innervated muscles, but they're specifically asking for the sensory one. So that this was a trick question. I put this on here to kind of just be like, see, they can ask about it every now and then, but these are also all muscles that the radial nerve innervates. It's just not specifically this branch. This is a sensory branch. And a lot of the times the superficial branch, these are all sensory branches. So the median nerve has a superficial branch. The ulnar nerve has a superficial branch, and they're usually sensory. Okay. So how do we injure this? So again, here's the radial nerve. It goes up the arm. It wraps around the back of the arm. It hits the tricep, right? So it goes behind the humerus, hits the tricep back there, and then it kind of wraps around, and it does a lot of extension stuff. So like finger extension, wrist extension, elbow extension. So it's pretty much trying to do a lot of those extensor muscles, and that's why here too, like the extensor digitorum, it's the Digitorum means like fingers, right? So digit, so it extends the digits. Triceps, we know it innervates the triceps. Flexor carpi radialis, actually this probably is not a radial nerve now that I'm actually reading the question. The flexors are not innervated by the radial nerve. Usually the extensors are innervated by the radial nerve. All of your flexor muscles are innervated by another nerve, which we will get to. Okay, so this one is radial nerve motor, so correction. This one's radial nerve motor. This one's radial nerve motor. This is probably another nerve that we'll get to. But again, regardless, superficial, none of these are it. Because the superficial branch is just straight up, it does not innervate a muscle. It's just straight up skin. And then, so in terms of this, so this is how you're gonna injure it is right here, right? Where the like compressing the axilla, so where the armpit is. So imagine like you put a lot of pressure under here, you can like hit this radial nerve right here and like take it out. So the number one way is like improper use of crutches. I don't know if any of you guys have ever used crutches. I've had to use crutches for a while. I tore my ACL, so I was on crutches for a while. And the number one thing my orthopedic surgeon told me was do not sit with your armpits on the crutch. Do not. You have to hold yourself up, which your arms get really toned from doing that. But that was the reason why, is because if you sit with your arms just on the crutch, you can injure your radial nerve. And that's when you'll get like these symptoms of like wrist drop, which we'll talk about. So that's the number one. So you can look for that in a vignette, like someone's been on crutches for a while, now they're having these symptoms. The second one's called Saturday Night Palsy, which I think is hilarious. But it's any instance where it's basically like you fall asleep or you do something where, you guys see this, my chair. All right, so here's my chair. You fall asleep with like your armpit on like a hard surface, like a firm object, so like a chair. So like, and if you fall asleep like this, that's enough time where it can compress your radial nerve because it's up in the axilla. So that's where this got its name, Saturday Night Palsy. Is like someone comes back drunk and they fall asleep like in a chair with their arm over it, and then that can compress their radial nerve. But it doesn't have to be a chair. It can be anything. I've seen questions where it's like someone doesn't come back drunk. It's just like someone came back and I don't know, they do talk about like just, falling asleep with their hand over the back of the chair, and then they woke up and had like all these symptoms. But that's kind of the idea of Saturday Night Palsy, is like someone's drunk, they fall asleep in a chair, and then now they have compression of their axilla, radial nerve. And again, it's compression of the axilla. Don't get got and say, oh, it's the axillary nerve. Remember, the axillary nerve's way up here. It's like way on the front up here. It has nothing to do with down here by the armpit other than like axillas in the name. Yeah, don't get got. People get got. It's like, oh, compression of the axillary nerve. They're going to be deltoid flattening. And it's like, no, it's wrist drop. It's totally, totally different. All right, so just pay attention with that. And then other things that you can kind of see, because this is a long nerve. So these are the two that are kind of like up where the nerve's up here in the armpit. But you can also see some injuries down here where it's kind of like making its way going down through the rest of the arm. So one of them is called a supracondylar fracture of the humerus. Condylar, the condyles are, so when the arm's coming down, actually, this is a good picture. So when actually, I'm just going to draw a bone. We're going to do a little bit of bone stuff right now. All right. So here is the glenohumeral joint. So this is like up where the shoulder is, and it's coming down. Now here's my elbow right here. So this is like where my elbow would be. And then it switches to like the forearm, right? And then like your fingers. So like 3, 4, 5. All right. Right here, like basically where your elbow is. Like if you feel your elbow, these two like little things sticking out of your elbow, these are your condyles. They're on the bottom half of the arm. So see kind of, well, not the bottom half, but they're like down here, right where the elbow joint starts, basically, like the elbow joint. You have a medial epicondyle and you have a lateral epicondyle. So these are just kind of like, you can imagine like little sticking things out here. And then it switches, to your radius and your ulna, which are the two bones that make up your forearm. So if you have a supracondylar fracture, that means right above these condyles, right above, so supra, right above the condyles, you have a fracture. So I fracture right above the condyles, which you can see in this UWorld image. Here's the condyles, here's the fracture right there. And if it displaces anterolaterally, meaning when this part up here, so it's going to fracture, and then after a bone fractures, it has to set somewhere else. Like it has to because again, it shouldn't be there. So it kind of sets either like anteriorly or laterally, laterally or medially. This is if it kind of displaces laterally towards the thumb, it can hit the radial nerve. And that's what this image is showing. So let me get rid of my text. So right here, so we have a supracondylar fracture, so we're above the epicondyles, and then there's a lateral displacement. So it goes towards like that lateral epicondyle. Boom, you can hit your radial nerve, you can take it out, okay? And another way to kind of remember all of this too is the radial nerve runs along the radius, right? So that's why the radius is the one that's right next to the thumb. So that's why people can remember like, oh, the radial nerve, it's like the thumb side. The ulnar nerve runs along with the ulna, and that's going to be the opposite side. Okay, so that makes sense. And the reason I mentioned like this lateral displacement is obviously you see the median nerve on this side. We're going to get to the median nerve. You can imagine it would get injured with an anteromedial displacement of a supracondylar fracture. All right, so again, it's just because of the anatomy. The radial nerve's on the lateral side. The median nerve is more medial. All right, so that's one of the other things. And then lastly, you can get a midshaft fracture of the humerus. This is the one I actually see the most. So a midshaft humerus fracture. So midshaft fracture, again, it's going to be, here's your humerus bone up here, so before the forearm, and the radial nerve, remember, it wraps around, so it kind of is back here where the axilla are, so this is where the armpit would be. It goes behind the humerus to go get that tricep, and then it kind of like comes back and runs in front, right? And that you can get a midshaft fracture right there. Like you can just completely like break your arm up here, and that's a midshaft fracture. You can hit the radial nerve. So that's what this is showing. Here's your broken arm. And this would be like a midshaft humerus fracture because that's your radial nerve in red. You get your broken arm, boom, right there. So watch out for radial nerve. It runs right next to the arm bone and is at risk for injury. So if you get that midshaft fracture versus like a surgical neck fracture, remember that's going to be more like axillary nerve. So again, where you get the break of the arm can kind of differentiate what nerve is affected because of where it runs. All right. And then your main symptoms. So let's say you do get a midshaft fracture of the radial nerve. So you're going to see motor deficits. You're going to get loss of elbow, wrist, and finger extension. A lot of the times this nerve does a lot of the muscles involved with extension. So you'll get loss of elbow extension, loss of wrist extension, loss of finger extension. And the best way to see this is wrist drop. So this is kind of what we were talking about earlier with wrist drop is like if you don't have anything holding this up, it's just you're gonna walk around drop like this. So like people will literally walk around with their arm, like with their wrist just dropping down. That's called wrist drop because there's nothing. So this is like, again, Saturday night palsy, right? You might have even experienced this maybe, who knows? But like you fall asleep with your arm over your chair like this, you wake up the next morning, you literally are like, oh my God, like I can't get my wrist up. That's because your radial nerve is kind of like going through it. You can also see decreased grip strength. The reason why is because a lot of the muscles in the hand that are involved with grip strength can also be affected by the radial nerve. And again, I didn't go into like the specific muscles. Overall, it's a lot of the extensor muscles of the wrist, the forearm, and the fingers. But you can see decreased grip strength. Again, this is not specific to the radial nerve. It's just something you can see. And then sensory deficits, remember there's a ton. So this lateral area here, and then a lot on the posterior side. And again, if there's one thing to take away with the radial nerve, it's like it does a lot of things on the back. So like all the extension functions of the arm, sensation pretty much on the back of the arm and the forearm. And then it does like this little lateral side over here. Okay. All right. Two more. So your median nerve, your ulnar nerve. So these are the last two. So your median nerve is going to be C5, C6 to T1. And the reason I mention like C5, C6 is because I see it both ways. Like I literally see it like sometimes it includes C5, sometimes it doesn't. But if you draw and kind of, so here's the median nerve. Technically, it is made up of C5, and I'm not going to draw them all out, but if you see it, it'll kind of be made up of both in terms of like all the different divisions. Like you eventually will get down to the median nerve, but just keep in mind some places say C5 is included, some places don't. I think, again, all of them are included, just like with the radial nerve, but just, again, it's one of those things where it's like, I don't know for sure, so you might see it both ways. So that's the median nerve. Those are its nerve roots. We're going to be at the point now where it's going to be like a lot of the same thing. We're moving our way a little bit down further the arm now. Like the median nerve and the ulnar nerve really don't have too many functions up here in that top part of the arm. It's really more so towards the forearm and the hand now with the median and the ulnar. So your median nerve, motor functions, we're going to start with the arm. It does a lot of flexing, and it does a lot of like stuff like going medially. And what I mean by that is like this is palms facing, where's the palm facing? Forward. Yes, no. Hold on. I have to like think about it in my head. So this would be the no, so this would the palm the hand is facing forward because here's the radius, here's the thumb. I think. Hold on. Hold on. Okay, yes. Sorry. I have to like when they don't draw the palm, I'm like, I can't tell. Yeah, the palm is facing forward here. So palms up. Here's going to be the medial epicondyle, so the body is going to be over here. It's going to do, and remember the median nerve runs on the medial side of the body, just like that one image from UWorld. So a lot of a lot of the muscles that it innervates are going to be a lot of the stuff that's involved, because now we're on the front of the arm, right? The radial nerve is a lot of the back of the arm stuff. Now we're on kind of like the front of the arm. So it's going to be like pronation. So like so when we're supinating, we're up like this. Pronation is going the opposite way. You need a lot of these like forearm muscles on the inside to do that, to kind of like help bring it that way. So it does your pronator teres, which helps with pronation. It innervates your flexor carpi radialis, which is really annoying because it has radialis in the name. But the way I kind of tell people to get around that is because this muscle is being named for the bone, right? So the radius is right underneath of it. But the main thing with the median nerve is it does all of like the flexor muscles, like a lot of the flexor muscles. It doesn't do all of them. The ulnar nerve does a few others, but the main two that the median nerve does are your pronator teres and your flexor carpi radialis. And the flexor carpi radialis does wrist flexion. Okay, so now we did wrist extension with the radial nerve. Now we're doing wrist flexion with the median nerve. Okay, so those are the two things here. I would say the median nerve and the radial nerve match up kind of nicely in terms of like this part of the arm, like the forearm. And then once it kind of gets down into like the hand, that's where it matches up a little bit more better with the ulna. So the median nerve truly is in like the middle of like these two other nerves. But think flexion, think like flexion, pronation in terms of the arm. And then when we get down to like the more of like the forearm hand area, it's going to do a little bit more flexion. So flexor digitorum profundus, digits in the name, so we know it's the fingers. So we're going to do finger flexion like this. So it does that one, and it also does thumb opposition. So thumb opposition is going to be like this. Like we have opposable thumbs because we're humans. This is the thumb opposition. Your median nerve does thumb opposition, okay? And again, that's going to be really important for one of the pathology states for median nerve palsy, aka carpal tunnel, which I'll talk about in a second. Okay, but it's kind of weird with because there's, like I said, there's a lot of muscles in the arm and the forearm, and I was just trying to think of like at least the main ones, because there's a lot to remember with the brachial plexus. So pronation, forearm pronation, wrist flexion, here are the two muscles, and then finger flexion, and here's the muscle, and then thumb opposition. I think I don't have the muscle isn't labeled on here, but I think it's like opponent, like it says like opponent in the name, or like like you can tell it's opposition because like oppo is like in the name, and it's for the thenar, like the thenar. I think it's like a thenar opponens or something like that. I think I have the name somewhere. It's just not on this picture. All right. And then sensory, in terms of sensory, it does just the hand on both sides. So it does the lateral aspect of the palm. So now we're on the palm. So again, you're thinking lateral. You're like, oh, like radial nerve. Like the radial nerve is lateral. But remember, the radial nerve only does the back of the hand. The front of the hand is going to be median nerve and ulnar nerve. But the median nerve does the lateral aspect of the palm. So that's what this blue one is, this palmar cutaneous branch here. And then you're going to get also these digits. So the lateral digits on the front. Okay, so notice like, again, the radial nerve did the back of these digits. The median nerve is doing the front of these digits. So 1, 2, 3, 3.5. So it's like the exact same as the radial nerve, just now we're on the front. And it also does like the tips of the fingers on both sides. And if you need to so fingers and fingertips of lateral 3.5 digits. So again, the radial nerve did the dorsum of the lateral 3.5 digits. The median nerve is doing fingers and fingertips anteriorly, so palmar side of the palm, and the fingertips on obviously both sides of the lateral 3.5 digits. Okay. And these are the two branches. And the thing I wanted to point out here is in carpal tunnel syndrome. So you can get median nerve injuries in ways that aren't. So I think when people think like median nerve injury, they immediately think of carpal tunnel, which is correct. But there's a lot of other ways you can get median nerve injury. So normally, if you like hurt your like lesion your median nerve, you will lose sensation in like the palm of like this, no, like right here, this lateral portion of the palm where the thumb is. Like you will lose sensation there. If you have carpal tunnel, you will not lose sensation just here. You'll lose them in the everything colored in green. Carpal tunnel, you'll lose sensation, everything colored in green. But in this area of the palm, if you have carpal tunnel, you will not lose sensation. This will be completely normal in carpal tunnel. It's a palmar cutaneous branch. And I'll show you why this branch is just, it doesn't go in the carpal tunnel. Like the median nerve kind of sends off all these little branches. Palmar cutaneous does not go. It just kind of stays on top of the carpal tunnel. So if you have carpal tunnel syndrome, it doesn't get affected. So you don't lose sensation here with carpal tunnel. Okay, so that's kind of like, I try to bring it up as much as possible because it's kind of like a weird thing because the carpal tunnel injures the median nerve, but then you don't have like this median nerve symptom and people are like, wait, why? Like, why don't I have this median nerve? That's why. This palmar cutaneous, and sometimes that's asked actually as like a test question. Like, why don't you lose sensation of the palm with carpal tunnel syndrome? It's because the palmar cutaneous branch is spared. Like the palmar cutaneous branch doesn't run in the carpal tunnel, so it will not be affected. All right, and then here's all the action. So here's forearm pronation. So that's your pronator. I'm going to go back. It's so fast. So here's your pronator teres. That's doing pronation of the forearm. Here is wrist flexion, so bringing it up, and then there's finger flexion. So kind of like the opposite of like the radial nerve. Here's kind of like your question. So median nerve function, what action is spared following injury of the median nerve? So you kind of have to go through this, think about like what things that the median nerve does, just like in the video we just watched. So I'm going to take a sip of water really quick. Great, yes. So what is spared following injury? Forearm extension is spared. Remember, forearm extension is going to be your radial nerve. That's your tricep muscle, does forearm extension. So like I said, median nerve does wrist flexion, does finger flexion, does forearm pronation. Forearm extension is going to be radial. Awesome. And a lot of the times this is how they ask those questions. It's like they really try to get at like the muscles that are innervated by these nerves and what action you lose. Because think about it, when you're a doctor, like that's how the patient's going to present, right? Like they're going to present with loss of function of something and you have to be like, wait, why suddenly can't you do forearm extension? So that's why they kind of like focus on the actions of these muscles that these nerves innervate. Okay, and then how would I get these injuries? So we are going to talk, so carpal tunnel is number 2, we'll talk about it. But in terms of median nerve injury and ulnar nerve injury, you'll see these terms proximal lesion and distal lesion. And this is just like an example of what they could mean. Proximal lesion is just like, it's a lesion to a more proximal portion of the nerve. And remember from like one of the first slides, proximal is closer to the trunk of the body. So like a proximal lesion could be up here, it could be up here, it could be up here, it could be here, like right here at the where the condyles are, right? It can be up here. A distal lesion is like closer to where the hand is. So like I lesion the median nerve all the way down here. I'm not like that's more of a distal lesion presentation versus a proximal lesion presentation. And unfortunately, you do have to start knowing the difference between like how a proximal lesion presents versus how a distal lesion presents, because it'll change up how the hand presents. And I hate the hand, like loss of sensation in the hand and like how the hand looks, like the different like motor things that happens with the hands. It differs if you have a proximal versus a distal lesion. So it's kind of annoying, but if you just kind of think about it, like if you have more of a proximal lesion, like more things are going to be affected, right? Than if you have a distal lesion, pretty much only like the stuff down here is going to be affected. So that's kind of how you can think about, but that's what's meant by like a proximal lesion versus a distal lesion. Proximal just means like higher up the arm versus distal is like closer to like where the hand is. All right. So just like with our radial nerve, shocker, it's super similar to the radial nerve, we have that supracondylar fracture, but now there's an anteromedial dislocation. So we have our, here is our humerus bone, and then here's our condyles, and then here's the rest of the forearm, and then the hand. All right. So this is going to be medial. This is going to be more lateral where the thumb is. Median nerve runs over here. So if I have a dislocation supracondylar, so right above these epicondyles right here, and now I have an anteromedial dislocation, so towards like the middle, like where the body is, I'm going to take out my median nerve. So that's what's meant kind of by an anteromedial supracondylar fracture of the humerus. So this is all stuff they would have to tell you. You can't just say like, oh, they broke their arm right above the epicondyle. Actually, they can say that. They can say like, patient broke their arm right above the epicondyles or right above the elbow joint. That's a supracondylar fracture. And now based on the symptoms, is going to be a median nerve injury? Is it a radial nerve injury? Based on like what symptom, like what functions did they lose, what sensation did they lose, things like that. And you can assume like, okay, if they took out the median nerve, that was an anteromedial dislocation, versus if they took out the radial nerve, that was like an anterolateral dislocation or fracture I should say. All right, and I only bring this one up, like spending a little bit more time on this one, this anteromedial humeral fracture. This is the most common pediatric elbow fracture. So this is, you have like a 10-year-old that comes in and they broke their elbow. Likely it can just like help you out with a vignette. It's like likely it's going to be an anteromedial, because this is the most common one, an anteromedial humeral fracture. Okay. But always use like the symptoms of a median nerve injury versus a radial nerve injury to actually like figure it out. Median, yes. So medial is more common than lateral. Good question. So we've talked about both types of supracondylar fractures of the humerus. The anteromedial is the most common pediatric elbow fracture. Anterolateral can still happen, but it's just not the most common pediatric elbow fracture. So if you see it, like again, a 10-year-old in a vignette that broke their elbow, and like let's say you like just forget that day, like every single symptom of a median nerve injury versus a radial nerve injury, you can kind of assume it's going to be a median nerve injury, because again, this is the most common one in a pediatric patient, so you can assume it's taking out the median nerve. But there should still be something in the vignette that helps you, like, okay, you're having these symptoms of a median nerve injury, not these symptoms of a radial nerve injury. More like flexion symptoms versus extension, because that would be more radial. Okay. Yeah. And then, so carpal tunnel, like I said, remember, palm sensation is spared. I cannot tell you how many times they like to ask about this. It's the palmar cutaneous branch, does not go in the carpal tunnel. So carpal tunnel syndrome, again, this is going to be more of like a distal lesion. So down here, carpal tunnel, there is like something called a carpal tunnel, and that's what this image is here. It's where all the carpal bones, so there's a bunch of carpal bones. The carpal just kind of means like wrist. So there's a bunch of like wrist bones here. And the median nerve, which you see in yellow, see how there's like this tunnel? It literally looks like a tunnel here. And these are just like tendons that are coming off of like a lot of the flexor muscles kind of go through this tunnel, this carpal tunnel. And then all like the wrist bones kind of surround the carpal tunnel. At the very top of the carpal tunnel, there's something called the flexor retinaculum. This is definitely something you should know. I think you cover this in OMM. Like I think there's a flexor retinaculum like massage or like soft tissue thing that you do, and the reason you do a flexor retinaculum like soft tissue treatment is for carpal tunnel, because that's like the tendon right on top of the carpal tunnel. So if you look at it from the top of the palm, like in this image, so again, this is palm. If you look at it here, here's the flexor retinaculum right on top. The carpal tunnel is right under that. So I can't really draw it because it's like going into it. But if you can visualize, it's going under this flexor retinaculum. Basically, that flexor retinaculum is the roof of the tunnel. And you can see the median nerve. This is the median nerve right here. It's going through that tunnel as well as all of these like tendons from all of those flexor muscles that the median nerve is innervating. Okay, and then carpal tunnel syndrome is when, let me get rid of this. So again, we're at the palm. This is like the hand is facing up. So this would be right here. That's like what I'm like referencing. This is like right, you can feel your flexor retinaculum. It's like right, well, I don't know if you can really feel it, but it's right here. Carpal tunnel is when you have compression of the median nerve, which again, it runs medially, and then it kind of comes down to where like the thumb side is. So it's going to kind of come on this side. And it's going to compress, right? So right where the flexor retinaculum is, it compresses that median nerve in between that and the wrist bones that kind of like surround it. So you basically get compression this way, and it compresses the median nerve. And then all the sensation that the median nerve innervates you're going to get like loss of sensation in these areas. So you're going to get like injuries here. So everything that's kind of shaded blue is going to be numb, except again, palm sensation is going to be spared. You're not going to have an issue with palm sensation. So like more like up here. It was honestly this part. This, like you won't have loss of sensation here. You'll more so have issues where everything that's green. And so in this image, I know it's probably showing it for simplicity, but your palm would be spared in carpal tunnel because the palmar cutaneous branch, and I think I have a picture to show this, but the median nerve is right here. It kind of sends a branch over the flexor retinaculum, and it does a lot of the palm area, like right here. So it can't be compressed in carpal tunnel. It absolutely can be compressed. Like you can lose that if you get a proximal lesion. Like if you get a proximal lesion, all of this is going to get affected. That's why when you see like loss of sensation, the palm is drawn. It's just specifically when you have carpal tunnel, which is right where the flexor retinaculum is pressing on the median nerve. That's when you get only the green and not the blue. Hopefully I'm explaining that okay. I'll show you an image. Maybe that'll help. But carpal tunnel is asked a lot. It's a very, very common injury. And the other thing I wanted to mention was I didn't know this until my first year of med school. The wrist is not, like everyone thinks the wrist is like here. This is not the wrist. The wrist is right here. So this is the wrist, which blew my mind the first time I learned it. But even your wrist bones are right here. And I bring that up for OMM because if you, like, let's say you're doing your OMM patient, like your SP, and you get like flexor retinaculum soft tissue or like I forget what it's called, what the technique is called, but you start, like, let's say you start massaging right here, you get a 0 because that's not where the flexor retinaculum is. That's not where the wrist is. It's up here. So you have to massage this part of the hand. This is where the flexor retinaculum is. Okay, and this is technically the wrist. And you're going to learn about all of the wrist bones. There's like 8 or 9 wrist bones. There's a ton of wrist bones. They're all right here. They're all like in this area. So all these carpal bones, they're all like in this area of like the hand, which I always thought was the hand, but apparently it's the wrist. All right, so just something to keep in mind. It is that it's drawn super high up in this image. That's technically where the wrist is. Fun fact. But okay, yes, I knew I put a picture in here. So before reading what I have on here, this is the palmar cutaneous branch. So if we kind of like if we're like orienting ourselves, this is the flexor retinaculum. So see this white thing like this? It's labeled transverse carpal ligament. The transverse carpal ligament, that's your flexor retinaculum. So this is another name for flexor retinaculum. So see how the median nerve goes under. So it's all this white, these are all tendons, right? So these are all tendons coming off of like those flexor muscles of the forearm. They're all going through underneath this flexor retinaculum. So is this median nerve, this bottom part right here, this median nerve. It's going underneath, and then you can see it kind of like gets a little like less drawn because it's showing it's going underneath of the flexor retinaculum. See how the median nerve sends this branch on top? So it sends out this branch. It's called the palmar cutaneous branch. It does not get affected with carpal tunnel. So if we get carpal tunnel, which again, I'm not showing that on this slide, but carpal tunnel is compression right where the flexor retinaculum is, this transverse carpal ligament. That is going to compress only basically all the other parts of the median nerve, but not the branch that's innervating the palm. And that's why you get no loss of palm sensation. Like your palm is not numb with carpal tunnel. You actually have feeling in your palm and it's totally fine. It's because of that palmar cutaneous branch. It goes above the flexor retinaculum. Okay, so that's like an anatomy question they can sometimes ask in terms of like the branch that's spared for carpal tunnel. But again, like I said, that's only for a carpal tunnel. For every other for every other median nerve, anything, the palmar cutaneous is affected. Okay, and that's why it's usually drawn with like the color. Like the color is like loss of sensation in this area because you do take out the palmar cutaneous branch. All right. But now for what we're talking about on this page, so if you get a superficial laceration of the palm, so if you get like, let's say like right here, like up here, superficial laceration, like you cut yourself, like you're cutting an avocado. I don't know. You're cutting an avocado and you missed the avocado and now you cut like superficial cut. It's not super deep. It's just like, boom, I sliced my hand open. You're like, oh my God. A lot of the times you and again, this, I don't know how commonly this happens in like life, but in vignettes, if you superficially cut your palm, a lot of the times you'll get motor deficits without a sensory loss, meaning you'll have no loss of sensation, no tingling of the fingertips, no tingling of the palm. Like you'll have no sensory loss. Sometimes you'll just hit this one branch. It's called the recurrent motor branch of the median nerve. It's such a small branch, but it comes up a lot of the times in like these questions about like slicing your hand open on an avocado. It's just this one little tiny baby branch. It's called the recurrent motor branch. And you can imagine this is the palm, right? Because this is the flexor retinaculum. So I'm here. So now we're up here a little bit higher. Boom, slice it. You're like, that is, you slice your recurrent branch, and now you only get motor deficits. So what that means is you'll only get stuff like, oh, I didn't even talk about the motor deficits yet, but you'll only get the motor deficits. You won't have any of like the sensory loss, like in this area. You won't have any sensory loss whatsoever. So you're injuring the median nerve without sensory loss. You're like, that's really strange. It's because of you're hitting that recurrent branch. All right. It's just like a weird thing. I wanted to include it because there's all these different branches that come up in vignettes for the median nerve. And then here I put, it's similar to carpal tunnel in the way that you're not really touching this palmar cutaneous branch. Like I said, I don't understand how when you slice open your hand, you're not getting this branch. It looks like it's right next to it. But just in terms of vignettes, like a lot of the times they just expect you to know, like you're only going to hit this recurrent branch. You're not really hitting this palmar cutaneous. Okay, so it's spared similarly to like in carpal tunnel. All right, and then so motor deficit. So what are the things that you'll see? Yeah, that's what I'm thinking too. Like maybe it is just more superficial. So like maybe it's hard to draw maybe. But maybe it's just like right under the skin. Like this recurrent branch is like right here. Maybe. Nerves are so tiny. Like they look really thick and like they're like literally like thinner than hair, right? So it's possible, but it's just something to keep an eye out for. It's like it's weird because you have this loss of motor function that sounds like it's a median nerve injury, but then you have no loss of sensation. You're like, can that be median nerve if I have no loss of sensation? Like that's really weird. Yes, you can have that, and it's if you hit specifically this recurrent branch, like the motor branch of it. Super weird. So how does this present? So we talked about the sensory deficits. Well, actually, I'll get to that in a second. Motor is going to be all those things that we talked about. So think about a lot of like the flexion. So it's kind of like the radial nerve's counterpart for like the forearm, but it does flexion. So it's going to be on the lateral side. Like I know in that one image, like I know in this image, it looks medial, but when it comes back down, it goes, and you can kind of see it here. So it does look medial at the elbow, but then when it comes, it kind of goes more here, center, and then it kind of goes to like the thumb side. So it kind of is like the radial nerve, except remember the radial nerve is on the back. It does a lot of the back stuff. The median nerve does a lot, and it's annoying because it's called the median nerve, but a lot of the times, like right at the hand, it does lateral, like it does the lateral fingers, right? So it does like the lateral 3.5 fingers, just like the radial nerve, but now it's on the front. And it does like a lot of the stuff over by the thumb, and you're like, that's weird. It's the median nerve, but that's the only reason why, okay? But think flexion with the median nerve. So we have loss of wrist flexion, opposite of radial. So we're going to not be able to do this. There's no like wrist, like the opposite of wrist drop. That doesn't exist. You aren't like walking around like this all day. You just can't flex. Like you just can't flex your wrist. You get loss of flexion of the lateral fingers. So like remember lateral is going to be anatomical position. So that's what I always say. It's always kind of confusing, but so this is technically lateral because this is thumb. So whenever you see lateral, just think thumb. So it's going to be the lateral 3.5 fingers, just like with the radial nerve, but it's flexion. Okay. And then also this does thumb opposition. So these are the muscles of the thenar eminence. Yeah, so I know I had the name of this muscle somewhere. So the thenar eminence, the muscles are the flexor pollicis brevis, the abductor pollicis brevis, and the opponens pollicis. Okay, so the median nerve only innervates this one, the opponens. And remember, look for opponent, the opposition, like it's going to be in the name. This is the one for that the median nerve innervates. It doesn't do the abductor. It doesn't do the flexor, okay, of the thumb. It does finger flexion with other flexors of the fingers, but for the thumb is like its own entity, and it has a lot of different stuff doing a lot of different nerves innervating a lot of different muscles of the thumb. But for opposition, this is only median nerve. Okay, so and I bring that up because one of the things for carpal tunnel is like they're not going to say patient can't oppose their thumbs, but it would be like patient came in because they were holding a mug and all of a sudden it dropped and it shattered everywhere, and they're like, that's weird. Like it just seems like their hand is like really weak, which, remember, grip strength, that's kind of like a radial nerve thing too. But with you need like thumb opposition to like I'm trying to yeah, you need thumb opposition to hold something like really tightly, right? So like let's say I have my phone. If I just like randomly drop this, it's because my thumb wasn't holding it enough. It was like I need like a strong way to hold this. And again, like in vignettes, they'll say like patient came in because they're just dropping stuff and they don't know why. They're just like things are just leaving their hands. And you're like, what the heck? That's usually a sign of like carpal tunnel, median nerve injury, something like that. And it's because of this thumb opposition kind of aspect. You need to be able to oppose your thumb to hold on to something. Okay, and then sensory deficits, loss of sensation over the thenar eminence, kind of like what we talked about. So in every way, you're going to lose sensation over the thenar eminence. The dorsal 3.5 fingers. I guess I meant the fingertips. I'll change this again too. So like the fingertips, because it's going to be the dorsal fingertips. But the dorsal 3.5 fingers is radial, like we talked about. And then the palmar aspects of the lateral 3.5 fingers. So now it's like the opposite. This is like the exact opposite of the radial nerve. So the radial nerve did the dorsal aspects of the lateral 3.5 fingers. This is doing the palmar aspects of the radial 3.5 fingers, but it's doing basically all the fingertips of the 3.5 fingers. Okay, and then of course the palm, but remember with carpal tunnel, you don't lose palm sensation, that stays intact. All right, and then the last kind of annoying thing before we go into ulnar, the median nerve and the ulnar nerve, there's going to be like these special findings. It's going to be various like hand presentations. I'll try to explain this as best as I can. It's confusing, it really is. But again, we're done after ulnar nerve. I tried to spend as much time. So if this is still confusing, please ask me, because this comes up a lot in terms of like having you differentiate between median and ulnar. So I just want to point out, so this is from first aid. If you look in first aid, these images are going to be exactly the same for ulnar. So these are the images for median. It looks like a hand like this and a hand like this, okay? So this is the first hand that I did. This is the second hand. So the first hand, it looks like this. The second hand, it looks like this. If you look for ulnar, they're the exact same hands. So that's what I think makes this confusing. But we're going to go into like what this chart means in terms of like the lesion, the type of lesion you see for a median nerve. So the first one is this one. This is called like the hand of benediction or the Pope's blessing. That's what they call this hand. So the hand of benediction or the Pope's blessing. The way that this doesn't just happen. Like it's not like the person with a median nerve injury is walking around like looking like they're blessing people like the Pope. Like what they have to be doing, and then this happens, is making a fist. So that's what context means. So context means you have a patient, you ask them, hey, can you make a fist for me? So their hand is like this. Yes, exactly. Very good. Yeah. So you already got it. See, this really confused the heck out of me when I was a first year. I was like, I do not understand this. I'm going to memorize this. It's not that bad. It's just like, I remember thinking like this made absolutely, yes, good. I'm glad that the context is there. Yeah. So what we're talking about in the chat is the patient's like this. You say like, hey, can you make a fist for me? And they make a fist and all they can do is this. That's it. So it looks like they're blessing you. They're like, hello, like the Pope's blessing. So it's the context of making a fist. This is what it looks like. And I'm pointing this out so much because this is the only way you can differentiate between this hand and then the exact same looking hand with an ulnar nerve lesion, okay? Which we'll get to at the end. So you ask them, hey, can you make a fist? They can't. It goes like this. It looks like the Pope's blessing. This is what a proximal median nerve lesion looks like. So you get again, it's going to be like anywhere up here, anywhere just above the wrist, you get a lesion, a median nerve lesion. It's going to look like this. And again, what we're talking about in the chat is because remember, with median nerve, what is a function of median nerve? Flexing fingers. It's flexing the fingers. So and it's the lateral 3.5 digits. So it's like the pinky, they can flex totally fine. The ring finger, it's like, okay, like, yeah, it's like half of it is like innervated. It's like 3.5, right? So it's like half of it, but it's like, okay, like maybe a little bit, but not great. They cannot flex these if you have a median nerve injury. So that's why it's like you try to tell them to make a fist, only these two go because the pinky and the ring finger can't flex. Like, sorry, they're totally fine with flexing. They're not innervated by the median nerve. Can this also be present in a distal lesion? Good question. So we're gonna get to a distal lesion next. It's kind of weird how I feel like this was just like how they were able to differentiate between a proximal lesion and a distal lesion. I don't know exactly why they present differently. I don't remember if I read the question out loud for the video, but it was like, could you also get this Pope's blessing in a distal lesion? Usually not, because it presents like number two. So number one is going to be your proximal median nerve injury. It's like you can't flex your lateral three fingers, so you can only get your pinky and your ring finger flexing. That's your Pope's blessing, whatever. If you have a distal lesion, again, I guess they just like, this is the best way that they can differentiate between the two. I don't actually know the answer to that question if this would present with a distal lesion, because I don't know enough about why this is happening with a proximal versus a distal. But in terms of like a distal lesion, you have you have like it's the opposite. You have the hand closed and you say, hey, can you extend your fingers? And remember, with median nerve stuff, there's no issues with extending the pinky and the ring finger. That's radial nerve. But you're still having an issue with these fingers. Like, I guess what they're trying, so like we're reasoning through it together a little bit, but with a distal lesion, maybe a distal lesion presentation is already to have, like maybe the fingers are already flexed. Like maybe it's like you take out the median nerve right here, like right at the hand. You can't even, like, it's just like that's how they're going to be now. They're just going to be in that context of like they're there. You can't do anything with them there. So in terms of like you get now a distal median nerve lesion, you ask the patient, hey, can you extend your fingers? Or just like normally at rest. That's why like at rest, I think is a key. Like just at rest, it looks like this. Like it just like, and I can't do it. I don't know. Maybe I have a median nerve lesion. I don't know why this finger can't go up, but this is supposed to be up. So I think like just if you have a distal lesion right at the palm, it's like, it's less about the function. Maybe you just truly take out like just those, like you just take out what it's innervating in general. So you take out the thumb, you take out the pointer finger, and you take out the oh my God, the middle finger, and you take out like half of the ring finger. And then you ask them to extend, or you just, you're just looking at the hand at rest, and this is how it looks. They call this ape hand. Sometimes they call it median claw. I see ape hand a lot more. There is an ape hand for the ulnar nerve, but like median claw it's a claw hand. Like sometimes they'll just say like a claw hand, but that doesn't help you because there's a claw hand for the ulnar nerve. So they call it a median claw. But I have seen ape hand more for like the median nerve lesions. And again, I guess think this is at rest. So this is just they're walking around. They have like a claw hand, just like walking around. Okay, so I think that's the main difference. The proximal lesions, and you'll see for both, even for the ulnar nerve, it's always going to be like that function of that nerve you can't do. So that's going to be like the presentation that it has, versus like the distal lesions is like, it's just how they are at rest. So at rest, we're going to take out the fingers that are innervated by that nerve. So it's just, they're going to walk around like this. These two fingers are fine. They're not innervated by the median nerve, so they can just do kind of like whatever. But these guys can't do anything, basically. You like basically took out the muscles that innervate those fingers in general. Make sense? Hopefully that makes sense. Cool. All right. The hands, man. The hands, I'm telling you, the hands is where the brachial plexus loses people. All right, and then lastly, we have our ulnar nerve. So our ulnar nerve is going to be your spinal root C8 to T1. So let's scroll all the way back to our picture. So C8 to T1. And that's going to be where your ulnar nerve is down here. So C8 goes down, boom, and then T1 goes down, boom. So that's your ulnar nerve. So now you can see we're at the very bottom of the brachial plexus. So we're like close to like the very bottom now. Oh my gosh, did I lose my spot? No. Okay. So functions of the ulnar nerve is going to be the ulnar nerve does a lot of stuff in the hands, like a lot of the stuff in the hands. The only thing it really does in the arm, like the forearm, is it runs right next to the median nerve. So the median nerve and the ulnar nerve kind of run like next to each other. So here's the medial epicondyle. It's just, remember, the median nerve, after it ran past that medial epicondyle, it ran back towards the middle, and then it kind of did like the thumb side, right, of like the palm. So it did like all the stuff over here for like the 1, 2, 3, like the lateral 3.5 digits was like the median nerve, because it kind of ran like that. The ulnar nerve is doing like everything else now on like the same, it's like everything that the median nerve didn't finish doing. So it's still a lot of flexion stuff. So remember, the median nerve did the flexor radialis. So the flexor, I think it's the flexor carpi radialis. So the one over here on like the where the radial nerve is, no, the radial bone, the radius. I don't know why I call it radial bone. The radius, because it comes over and then it goes over like this, and it does pronation and it does flexion of the forearm. So it does do that, but it does specifically the flexor carpi radialis. The ulnar nerve is still going to do flexion, so it's still doing flexion of the forearm, but it doesn't do the flexor carpi radialis. It does the flexor carpi ulnaris, and it's in the name, which is nice. And then another one that it does is the flexor digitorum profundus. And digitorum, remember, digitorum is going to be digit, it's fingers. So it's going to be flexion of certain finger muscles. So you can assume it's going to do everything that the median nerve didn't do, and that's exactly what's happening. So in terms of the fingers, it's doing flexion of the ring finger and the pinky finger, because those are the two left over from the median nerve. And it's going to do flexion of the, flexor carpi ulnaris. So it's just going to do, it's the same thing as like the flexor carpi radialis. It's just sometimes they ask about the specific muscle that the ulnar nerve innervates versus the median nerve, because they're so similar. The median nerve, remember, kind of is like more lateral. It kind of does what the radial nerve does, but on the front side of the forearm. The ulnar nerve does more medial stuff. So it's going to still do flexion and adduction of the wrist. Wrist adduction, remember, adduction is going to be towards the body. And remember, standing anatomical position, oh my gosh. So like if this is like this, adduction would be close to the body like that. So this is what the ulnar nerve does. And if you do it right now sitting there, you can probably feel like this muscle closest to like the pinky. It feels like it's flexing when you're doing adduction of the wrist. Okay, so that's what the ulnar nerve is innervating, and it's innervating the muscle that flexes the pinky finger and the ring finger. In terms of the hand itself, it pretty much is responsible for all fingers, abduction and adduction. Okay, so the names of those are going to be like flexor digiti, like little things like that, abductor digiti, opponent. So it does, I guess it does opposition as well as like the pinky, but no one really asks about pinky opposition. But abduction and adduction of the fingers is the ulnar nerve. And no, it's not just like these two. It's not just the ring finger and pinky finger. It's all them. So it's all abduction, adduction of all fingers. The ulnar nerve is like very big in the hand. It has a lot of stuff that it does in the hand. The median nerve is really big in terms of like opposition. The radial nerve does extension. The median nerve does flexion. Median nerve also does opposition of the thumb, but the ulnar nerve does abduction, adduction. Okay. And then sensation, it's going to be front and back. So this is going to be anterior, posterior. This one actually does front and back. So it's a little on the hand, in terms of the hand. It's a little different in terms of the median nerve in that regard. So if you think anteriorly, though, it's going to be the opposite of the median nerve, right? So remember, the median nerve did, I'm going to color it in red. This is pretty much everything the median nerve did, everything in red. So it did the lateral 3.5 digits. And remember, it also had that palmar branch that's spared in carpal tunnel. And it did the fingertips on both sides. But you can see with the ulnar nerve is doing pretty much everything else. So it's going to do the rest of the palm, and it's going to do the medial 1.5 fingers. So again, it gave you medial. So we have 1.5. Okay. On the back, it's doing the dorsal surface of the medial 1.5 fingers. So remember that the fingertips of, and I like these pictures because it outlines, I guess, where the median nerve did. So the median nerve is going to do everything in red that I'm doing in red. It's going to do front and back of the fingertips, right? So front and back of the fingertips. But then the ulnar nerve is basically doing the dorsal surface. So this is the back of the hand of the medial 1.5 fingers. Okay. So at the end of the day, it does the same thing on the front and the back, right? It's doing the front medial 1.5 fingers, and it's doing the dorsal medial 1.5 fingers. So it's doing the same on the front and the back. It's just different branches. The median nerve is weird and the radial nerve is weird in terms of the hand. All right, so in terms of the functions with the video, so it's going to do wrist flexion, it's going to do finger flexion, some finger flexion, does wrist adduction, right? So that's, again, medial, finger abduction, and finger adduction, all right? So in terms of like, so it's going to flex remember, it's going to flex the pinky finger and the ring finger specifically, but it does abduction and adduction of all the fingers. Okay, it's not just the ring finger and the pinky finger. Sensations that. So again, wrist flexion, finger flexion, but again, pinky finger, ring finger. Wrist adduction, so closer to the body. Finger abduction, and then finger adduction, all 5 fingers. All right. So here would be like your question. So ulnar nerve function, where will a patient have sensory deficits if experiencing ulnar nerve palsy? So they're just straight up asking you. Beautiful. So patient's going to experience medial 1.5 fingers. So again, opposite of opposite of median. So it's going to be the medial 1.5 fingers. If you kind of go through all of these, so lateral 3.5 fingers, regimental badge area, strip of skin down the middle of the arm. We've talked about all of these. So lateral 3.5 is going to be median. Regimental badge is your axillary. Remember, that's the deltoid area. And then the strip of skin down the middle of the arm on the back, that's your radial. Because remember, the radial does a lot of like extension stuff. So it's a lot of the stuff like on the back and like that area on the back and the dorsum and whatnot. Okay, cool. So how do we get an ulnar nerve injury? So the first thing, so this is how the ulnar nerve runs. So it pretty much stays close to the inside of the body the whole way down. Like it just kind of like doesn't really do anything fancy. Like the radial nerve kind of does all weird stuff. The median nerve starts medial and then it crosses over. The ulnar nerve kind of just like stays in a straight line. It's kind of nice. It's not trying to no frills. So the first thing you can see is fracture of the medial epicondyle. And I want to point out this is a true fracture of the actual medial epicondyle. So remember, we drew the lateral and the medial epicondyle. If you straight up fracture, so I liked this this x-ray, the medial epicondyle just completely just like breaks off. That can injure your ulnar nerve if you have the supracondylar fracture up here, so above the condyle, and then it medially deviates, that's still your median nerve. But if you fracture the actual medial epicondyle, now it's your ulnar nerve. It just must be in terms of like where it's running specifically. Like the ulnar nerve really isn't injured with the supracondylar fracture, but it is injured as soon as you injure that condyle. Okay. The one that I see the most is the fractured hook of Hammett. Hook of Hammett. And you'll also probably cover this in OMM. There's a mnemonic. It's called a Fouche injury, or you'll see it. You'll just like see like, oh, patient injured hand in a Fouche injury. Fouche stands for fall on an outstretched hand. So fall on outstretched hand. So imagine you're walking. A lot of the times it's like older people. So it's like you're walking, you trip over something and you like put your hands out to break your fall. A lot of the times that can fracture your hook of Hammett. And your hook of Hammett is this little hook, which I don't even know, I can't even feel it on me, but apparently it's there. And again, these are your carpal bones. So like I said, there's a lot of carpal bones. I don't have all of them listed on here. You will have to know all of those, at least for OMM. You'll have to know, you should definitely know all the I feel like they asked a lot of questions about the carpal bones in terms of like whenever you cover this stuff in OMM, they ask a lot about the carpal bones. I forgot to mention this now that we're talking about carpal bones. The carpal bone that most commonly leads to a carpal tunnel is called the lunate bone. And there's mnemonics. There's like, I think there's an Anki card with how to remember all 9 or however many carpal bones. But the lunate bone is the one that most commonly leads to carpal tunnel injury. And again, it's just one of the bones that if you fracture it, it goes forward and it like just takes out the median nerve and you can get carpal tunnel. That's the lunate. In terms of this guy, like a fallen and outstretched hand, you can fracture the hook of Hammett, which is this bone, which you can see it's colored yellow. I'm not going to color it in red, but it's colored yellow. These are all carpal bones actually right here. Like 1, 2, 3, like there's a bunch, 4, 5, 6, 7, 8, 9. I think there are 9. So there's all 9 here. The hook of Hammett is the one right underneath where the pinky is. It's like right here. And there's a hook. It literally, there's a little, like, it looks like a little hook. It like sticks out like that. And the ulnar nerve runs like right along that hook. So you can see in this image, this is the ulnar nerve. So deep branch of the ulnar nerve, right? So it's coming, it's coming, it's coming, it's coming. And then it like sends these branches out, like the ulnar, it splits, right? Like all these nerves split. I'm sorry, it's in red. That's really, oh, I know. So let's say here's the ulnar nerve. It's coming, it's coming, it's coming. It sends all these branches out like this. You can see this is where the hook of Hammett is, right here, this bone, and it just sticks out like this. It just like sticks out. If you fracture it, like it's showing here, like boom, you get this little red fracture. You can take out this ulnar nerve that's right there. Okay, so, and a lot of the times they don't tell you, patient has a hook of Hammett fracture. Like they don't say that. They'll say like patient fell, like they were walking, and sometimes if they're being nice, they'll say patient fell on an outstretched hand, and you're like, oh, foosh injury. But a lot of the times they'll just say like patient was walking and fell like face forward and caught themselves with their hand. Like they'll say something like that, and you're like, oh, and now they're having these symptoms of like an ulnar nerve lesion. And you can be like, okay, that's probably like a hook of Hammett injury. Okay, so these are the main two. The next one's called Guyon canal syndrome. Guyon canal is pretty much identical to carpal tunnel. It's just now the opposite side. It's like now on the ulnar side. There's a little tunnel. They didn't want to call it a tunnel. They wanted to call it a canal. Fine. So it's basically a tunnel though. And it's the ulnar nerve runs through it with its artery. So it's like the ulnar nerve, ulnar artery. And I actually mentioned ulnar nerve, ulnar artery. I feel like I got this question on OMM, like one of the OMM SP like flashcard questions was like, what runs in Guyon canal? And you're like, I don't, like, what? Like I remember getting that question being like, I don't even remember what Guyon canal is. But it's just like the ulnar nerve, ulnar artery, done, right? It's like, what are two things? Those two things. But so that here's the ulnar nerve, here's the ulnar artery. They make up Guyon canal. And it seems like it's kind of like, where is this kind of thing? It's basically so this is the flexor retinaculum. So this white thing again. So here's the carpal tunnel. See how big the carpal tunnel is? It's nice and big. This is the carpal tunnel. Here's all of like the tendons that come off of the flexor muscles of the forearm. Here's your median nerve. Right, so that's your carpal tunnel. So you can see the location of the Guyon canal in reference. It looks like almost like it's sitting within the flexor retinaculum. I don't know if that's true. I mean, it might be. Couldn't tell you. I don't know. I haven't seen it. But it does sit like more closer to like the pinky side, obviously, because we're talking like ulnar nerve. We're talking like pinky side. So it's a little bit further like medially. And it's pretty much the same thing as carpal tunnel. You get like compression of this canal, you can take out your ulnar nerve. And when do you see that? Bicyclists. And I pretty much have never seen a Guyon canal question where they don't talk about someone's a biker. So they'll talk about like if there's drop down handlebars, which is like if you've ever seen bikers and they're like sitting up and they're like their handlebars are like below them. So they're trying to mention like there's gravity, right? So they're standing up, there's like gravity pushing down on where the like where the handlebars are when they're holding their bike. Just like this, honestly. Boom, that's your Guyon canal syndrome. You can like crush your ulnar nerve. And again, kind of like we'll talk about it, but you lose sensation in the area that the ulnar nerve innervates, and you lose all those functions of like the ulnar nerve. And there's no like special circumstance like with carpal tunnel where like, oh, so you don't get like palm superficial like loss. Like, no, it's like everything goes in Guyon canal. There's no like special branches to like be aware of. So these are some like things you can see. Guyon canal syndrome, the medial epicondyle fractures off, like this is all stuff you can see. So you can see motor deficits, you lose wrist flexion of the 4th and 5th digits. So again, like I said, that's going to be your pinky finger and your ring finger and your pinky finger. Loss of wrist adduction. So what we've talked about, loss of finger adduction and abduction, so minus the thumb. Loss of finger yeah. So again, minus the thumb because the thumb has its own kind of like innervation scheme. And then sensory deficits, everything we've talked about. So it's going to be basically pretty much the opposite of the radial nerve and the median nerve on the front and the back of the hand. It's just going to be everything that's kind of left over. I like this picture from first aid. I keep putting it in here. It's like these 3 nerves are innervating like the front and the back of the hand. And it's just funny that you need so many nerves to innervate. So then finally with the claws. So we're going to, again, like I said, these are the exact same images for the median nerve. It's just now they're called different things. So we have, kind of looks like the hand of benediction, but it's not called that. Now it's called the ulnar claw. Okay. And then over here we have, it's called like the OK gesture. So it's like this. So again, it's what the ape hand is, but now on the ulnar nerve. Okay. So the first one that they do is let's start with proximal, just like we did last time. So remember proximal, we kind of decided is going, like the proximal lesion, we've decided that's going to be when you tell the patient to do something. So like, hey, can you, for the median, it was like, can you make a fist? And like, here's what they could do, what they couldn't do. Same thing here. Can you make a fist? Now the fist is going to look like this. Because again, they have no issues making a fist with these fingers. It's these two that they can't do anything with. So again, here's an example of what would a proximal ulnar nerve lesion be? A fracture of the medial epicondyle. So you say like, hey, can you make a fist? They go like this. You're like, oh, that is an ulnar nerve lesion because these fingers can't flex and you need the ulnar nerve to do that. Versus like, hey, can you make a fist? They do this and it's like, oh, that's the hand of benediction, right? That's the median nerve injury because you need the median nerve to flex these fingers, okay? So the proximal lesions are going to be when you're telling the patient to do something and they can't do it. So this is what the OK gesture looks like. And then this is what, again, first aid calls the OK gesture. So it's like this. In terms of the distal lesions, this is going to be like at rest. So again, we take it out close to like where the hand is. Now it's just like nothing can happen at that level. It's just like at rest. Now the muscles are taken out, so nothing can really happen. So at rest, it's going to look like this. So again, it's kind of the opposite of at rest for the median. Now it's like these two are taken out because they're innervated by the ulnar nerve. And a distal lesion, it just takes them out, can't do anything. So at rest, it looks like this. And they're saying that this is the ulnar claw. This is not the same. I know for like the median claw, I said like, oh, that's your ape hand. This is not also called ape hand. It's usually only called ape hand with the median nerve lesion. And the reason why is because remember with the median nerve lesion, at rest, it's this one. At rest, it looks like this. Is the ape hand, right? So it looks like this at rest, just like apes, I guess, are walking around like this, I guess. So that's at rest. Here, it's not the case. This is not at rest. Well, this is at rest, sorry, but it's the opposite. It looks like this. So they call that the ulnar claw, but there's no like ape hand because I guess apes more so walk around like this. Okay. So that's that. And again, an example of a distal ulnar nerve lesion would be like a fractured hook of Hammett or something like that. So a few summary slides before we end here. So this is just for studying purposes. It's what the muscles are innervated. Muscles are innervating, the motor actions of that nerve, the sensory innervation, and then like how the patient would present, and then any special. So meaning like the claw, hands, like anything like that, which is just mostly medial and ulnar. And then in terms of like, so the reason like muscles innervated is important is because if you were to injure any of these nerves, these are the muscles that would atrophy. If you were to injure any, like this nerve, these are the actions that you would not be able to perform. And then same thing with sensations. You would not be able to perform, like you would not feel any of these sensations. But again, remember that carpal tunnel, I might put like a little note here. Remember that the anterior palm is spared in carpal tunnel, but everything else can be affected. And then just so I don't know if you guys are familiar with the 100 Concepts PowerPoint. I talk about it every now and then. I put some slides in here. The 100 Concepts PowerPoint is, I think, really good for MSK in terms of MSK questions. So I have them all on here for you guys to go through, but I did want to talk about a few. So I pulled out the one, and you guys should all have this. If you don't have this, I'll upload it because it is good for you to have just to see like what are the top. It's basically like the top 100 concepts that come up on boards in terms of anatomy. Yeah, no problem. I'll upload it. There's an Anki deck that I really recommend, especially for second year. Like this is how I kept up with my anatomy for second year and it's like the anatomy deck is like 100 cards. There's like not any cards. And I would unlock them as we did each block. So it would only be like 5 to 10 cards every block. So it wasn't anything like too aggressive for second year, but it's kind of how I kept up on my anatomy. And when I tell you like every single anatomy question I got came from this PowerPoint, the only anatomy I was asked on both sets of boards came from this PowerPoint, which is saying a lot, which really is saying a lot, especially for COMLEX with MSK. But just to kind of round out this session, instead of doing more questions, I wanted to highlight some main concepts from the 100 PowerPoints deck. So remember, whenever you see this slide and I throw it in like a PowerPoint, this is from the 100 Concepts Anatomy deck. This is kind of, these are technically in the poem section of the 100 Concepts deck. But the reason why is because it's a lot about the scalene muscles. But in terms of like gross anatomy, where the brachial plexus is, right? It's going to be up in the neck. So this is talking about something called the axillary sheath. It basically is like on the outside of where the scalene muscles are, and that's what basically encloses all the axillary arteries, but also the brachial plexus. Okay, so you can kind of see it here. What it's pointing at is the brachial plexus kind of coming out of the neck. And then another thing in terms of like this sheath is, here's like the scalene triangle, right? So the posterior triangle, what is it? The posterior triangle of the neck. It's mostly made up of the scalenes. This is all stuff that you've probably covered in palm and like maybe like cardiovascular. But I only bring it up again is because located within this scalene triangle are the trunks of the brachial plexus, the branches of the brachial plexus. So it is kind of here. So you can imagine if you have tight scalenes, you might have some non-specific brachial plexus side effects. And that's what I was kind of mentioning way in the beginning is like, I know I didn't really go into like, well, if you have an upper trunk injury, how will that present? And you can imagine it would be like, if I go back really fast to here, like you can imagine if I take out like the upper trunk, for example, right here, I just take this trunk out. What are all of the downstream branches affected? It's like the radial, the axillary, and the musculocutaneous and the median. So you might be doing a question and it might seem like all four of these are out, but the only one intact is the ulnar nerve. They might ask like what's affected, and they'll talk about the trunks. They might ask about the divisions. They might ask about the cords. So that usually they ask about trunks in like that instance. So it's there's only three, which is nice. But that's kind of like why I put it here. It's more of like a second year-ish thing. But just keep in mind, like you can have like an issue with the scalenes and take out like an entire trunk of the brachial plexus, and then imagine all the downstream effects you can see. Okay, so I would say less for this exam, but just know that the trunks are located up in the neck. Remember, like I said, all the upper limb fractures. I like this slide. It kind of like summarizes all the ones we talked about. So it talks about the surgical neck fractures, taking out the axillary nerve, the midshaft fracture, taking out the radial nerve. Supracondylar can take out either the radial or, the radial. It can take out the radial or the median. I don't know if it says, it doesn't talk about the radial for the supracondylar, but I think they're probably talking about the more common one, which is the one that they see in like pediatric patients, which is going to be that anteromedial dislocation. But just keep in mind, if it does kind of go laterally, you can see a radial nerve lesion with a supracondylar fracture. And then if you fracture the medial epicondyle, you take out the ulnar nerve. Okay, so this is a nice like summary slide. Carpal tunnel syndrome. So this is going to be a dislocation. Oh yeah, here we go. So dislocation of the lunate bone. This is the most common carpal bone that causes carpal tunnel syndrome. Okay, and then clinical manifestations, everything we talked about. Here's the palm sensation is spared, so palm sensation is not affected. The palmar cutaneous branch goes above it, like kind of goes above that flexor retinaculum, that transverse carpal ligament goes above it, so you will still see, boom, right here, like you'll still see the, oh my God, palm sensation. And then finally, like it's saying the ape hand deformity. So there we go. We're talking about like the ape hand, right? So you'll see the ape hand deformity again at rest. So it's going to be like this at rest. And you're not gonna be able to oppose your thumbs. So this is like usually, I forget, this is called something. It's like a test you can have the patient do to see if they can oppose their thumbs. But you basically give them like I don't even know, you give them like a piece of paper like this. You give them like a piece of paper and you just see if they can just kind of hold it up and like oppose their thumbs. Like they're gonna need to have thumb opposition to switch their fingers like this, and if not, like the paper will drop. I guess I didn't really need to show that. It's kind of obvious, but that's how you can like clinically test for thumb opposition. This will come up on your exam for sure. This is different types of, so this is like lesion of the upper limb nerves, and this is like upper brachial palsy. I know I said like we weren't really going to go into like roots and trunks, and I'm not really going into it, but this does come up. I feel like this did come up on the exam, so I did want to talk about it. I knew that there was a slide on the 100 concepts. So This is, you just injure the upper roots and the upper trunks of the brachial plexus. And a lot of the times you can tell that this is the injury because of how the patient sustained the injury. And there's one for lower trunk. So this is the upper trunk. It's basically like you fall. So see how it's like excessive increase in the angle between the neck and the shoulder. So like someone falls. I think the question on our test, or like one of the, I don't know, but it's like someone falls out of a tree or something and they like fall on their neck, and it's like it extends the angle. Because remember, the upper trunk is like right up here. So extends the angle. So like C5, C6 roots, or that superior trunk, that's what gets lesioned. So usually it's kind of obvious that's what they're talking about. It can just injure the entire brachial plexus, kind of like we talked about. It's like every single branch gets affected except the ulnar nerve. Or, and this is where it kind of comes up a little bit more commonly, birth injury. There's two birth injuries. This is one of them. And it's like when you, like, let's say the baby's born breached and you try to pull the head out. So like you grab the baby's head and you try to pull it out of mom, you can injure the baby's brachial plexus, which is wild. So if you ever see that in a vignette, they might, and then they'll start talking about, like they can't do this, the baby can't do this, baby can't do that, baby has wrist drop. Like they'll talk about things like that. That's usually what happens. It's that upper trunk injury that happened because of birth. On the opposite side, this is called Klumpke's palsy. So Klumpke paralysis, Klumpke's palsy. This is a lower brachial plexus injury. So the exact opposite. Oh my God, the poor baby. Yeah, so this is horrifying, and then this is also horrifying. So this is on the opposite spectrum. So now it's the lower trunk. So lower roots, lower trunk. And we can go back and draw it, but you can kind of do it on your own. But this is now like the opposite. So the one was you fell from like a tree on your neck and like stretched it from the top, or the baby, you pulled the head out from like so it's very like up here. Klumpke is going to be the opposite. So it's like the bottom. So it's like you have this stretching from the bottom. So this is the same thing. They fall out of a tree, but now instead of falling on their neck, like the last example, now it's like they grab a branch. And this is like the only way I've ever seen this asked in a question, honestly, is like they're falling out of a tree and they grab a tree branch. And it's like, you know how it happens so fast and you just grab a branch and it's like you're hanging? That can like injure the lower trunk and the lower branch, like the lower roots of the brachial plexus. So it may occur when the upper limb is suddenly pulled superiorly. So I think that's why they always use the tree branch example, because that's pretty much like the only way you would see this. But you basically stretch or tear that bottom part of the brachial plexus. So it's like where T1 is, C8, it's like kind of like pulls it like that. So grabbing support during a fall from a height, or a birth injury. So this is the opposite. You're not grabbing the head. Now you're grabbing the baby's arm, which again, wild. So the baby's in there, you're trying to get it out. You grab the arm, you pull the arm. You can, again, lesion the bottom part of the brachial plexus just like in this way. And then it'll be like opposite symptoms. It would be like ulnar stuff versus like axillary stuff and whatnot. Okay. This is called, so this is another example of Klumpke's palsy. So this could be how like it could present. So again, this is like how you can get it. This is how it can present as Klumpke's palsy. So intrinsic muscles of the hand are supplied by C8 and T1, right? So we talked about that. So you get combination lesions of the ulnar nerve and the median nerve. So you get that ulnar claw and like that median claw, which again, they refer to as ape hand. And again, if you follow like the lower trunk, I'm sure it's probably actually, let's just do it. We have 3 more minutes. Let's just do it. So we lesion this anterior trunk, which would be right here. So that is going to be T1 goes here, ulnar nerve, and then C8 goes here, median nerve. Yep. So it's a combination of like median nerve and ulnar nerve defects with like an inferior trunk or like a lower trunk injury. And remember, superior trunk, which would be the one where they like fell on their neck like that, or the baby's head, they pull it out. That would be like all the other nerves except the ulnar nerve. So where's that one? Here. So basically combo of ulnar and median stuff. But a lot of the times it gives it away based on like how the patient sustained the injury. But this is called Klumpke's palsy. You might hear this come up every now and then. It'll be on the Anki. If you're doing the MSK Anki deck, it should come up in that. So here's injury to musculocutaneous nerve. So again, remember musculocutaneous is anterior bicep. So this is going to be, like I said, usually results from lesions of the lateral cord. It was in that image, like the lateral cord is just where the musculocutaneous nerve came out of. And we talked about this flexion of the elbow, supination, as well as the sensory deficits. But remember, it could be a anterior bullet, right? Right, like, sorry, a bullet to the anterior bicep. That can also take out the musculocutaneous nerve. Cutaneous innervations of the hand. So this is just another reminder of the ridiculousness that there's multiple nerves that innervate the hands. So this is showing the dorsal hand. Remember, it's mostly going to be radial for those lateral, like 3.5 digits, but not the fingertips, because remember, fingertips is just median. Ulnar nerve is going to do basically the entire back of the medial 1.5 digits. Flip the hand over to the front, so the palm's in the front. Now it's going to be the median nerve kind of takes over everywhere where the radial nerve took, but now on the front of the palm, as well as all the fingertips, like we talked about for the lateral 3.5. If you have carpal tunnel, this is spared. And then ulnar is going to do front and back on that side. And then finally with questions, we're not doing questions, but I was going to like pick some out and put them on here, but I really think like there's not that many on UMichigan Anatomy. There's not that many, so I would just do all of them. I'm not going to put an extra section with the questions, but this is the link. This like brings you right to the link. I hope this works. I'm going to show you really quick. Skip verification. Hopefully you can see it. Can you see that? Is it popping up for you? Okay, cool. So this is how it looks. UMichigan Anatomy, like you can find other practice questions, but I personally found their ones for brachial plexus, shoulder, arm. Like we didn't talk about everything with the shoulder today. These are the best, like by far. And I'm not going to do them maybe I'll do one with you just to kind of show you, but you just click through. So you just toggle, you can click or you can press like the arrow. So it says like each slide will have a question, possible answers, click anywhere to reveal, click again to move to the next. And they give you explanations. This is like exactly how your MSK questions are going to be on your exam. It's actually insane. I feel like they co-wrote the questions with UMichigan Anatomy. But yeah, it's really good. And I had all of my second year students that I tutor for boards redo these, because this is also how a lot of the MSK questions come up on boards. Actually, this is a good one because we really didn't talk about this. Oh no, did we? After ramming the point of their shoulder into a practice dummy, football players suffered severe shoulder separation. This dislocation of the acromioclavicular joint, several structures could be torn, including the one that gives the joint its greatest strength. Yeah, so we didn't talk about this, so this is a good one to do. So it's just saying like what muscle or like what ligament gives the acromioclavicular joint its greatest strength. And I don't even think that's something you need to know for your exam, but let's say we pick, I don't know, the coracoacromial ligament, like B. So I'm just going to click on the slide. No, the answer C, coracoclavicular. Isn't that what I said? Oh, I said coracoacromial. Okay, so coracoclavicular ligament. And then it goes through like why all the other ones are wrong, why this one is right. It's really good. And then when you're done, you just go to the next question. And again, this one is all shoulder, brachial plexus, and arm. So if it's stuff you haven't seen, just like go through it and be like, I haven't seen this yet. Like I probably don't need to know this. Like you'll get to brachial plexus questions. I don't want to toggle through all of them, but just kind of toggle through them, see what you like out of them. And yeah, this great source. And I didn't put on here like let's just do it together. UMichigan Anatomy. How you get to this is you just type in UMichigan Anatomy. Click University of Michigan Medical School. They have dental school questions, but I don't click any of these. I just go to resources, practice questions. And it's going to say M1 and D1. D1 is going to be like a lot of like, that's your dental students. So that's going to be a lot of like head and neck anatomy, where you go to M1 and then you scroll down. So there's a lot of cool ones. So here's like forearm, wrist, and hand. So the brachial plexus ones are going to be more like arm and whatnot. But if you want to ask more about like those different hands and whatnot, you can do forearm, wrist, and hand questions here. So maybe I'll put this link in there as well. But it basically just asks a bunch of anatomy questions, and they're really, really good. The ones for I don't love other questions on here for anatomy, but their brachial plexus ones are really good. Their lumbosacral plexus ones are really good on here too. Okay? All right, stop. Okay, well, I hope that was helpful. Yeah, no problem. And I will see you guys another time later. All right, bye.